we will move on to our next presentation, which is done by two individuals on research and some pediatric registries for Brugada syndrome as well as CPVT. So first we'll have Dr. Cecilia Gonzalez Corcia, who is a pediatric electrophysiologist with an expertise in devices and inherited cardiac conditions. And she was mentored for her PhD studies in Brugada syndrome by Professor Pedro Brugada himself. She's authored many scientific papers on Brugada syndrome and practices now in Montreal, Canada. She'll give us an update on her pediatric Brugada syndrome registry first. So welcome, Cecilia.
Hello, everybody. Hello, Marcia. Hello to all this wonderful group of people. It is a pleasure for me to be invited to be here and to share with you my research, my activity of the last couple of years. Thank you for this nice introduction as well, and we will kick into the subject. Let me share my screen. And excellent. I will do this. And we are ready to go. So I had, I'm originally from Argentina, but I had the wonderful opportunity of working with Pedro Brugada when I was living in Brussels many years ago. And this is how I started my research on this disease that we know now as a disease of the adults because it's mainly expressed around 35, 40 years of age, but we know well that the first children that Dr. Brugada described in his initial paper were, in fact, two young siblings of age 11 and 4 years old that presented with this typical pattern of right bundle branch block and persistent ST elevation in the right precordial leads. And they had severe and profound syncope and sudden cardiac death. The elder son actually died. Pedro identified with his brother Joseph in 1992 this typical electrocardiogram that included abnormalities in the repolarization and depolarization of the heart. And this includes ST elevation in the right precordial leads and very, very abnormal right bundle branch block, and sometimes a negative T wave. These are the patterns that are distinctive features of the disease, but that rarely present, and that is a challenge we have with children, especially. No? So working with Pedro, I had the opportunity to look into all the database of families he had collected for a period of 25 years. And I realized that there was a well-established pathway of follow-up and management of the adult patients, but that in fact, the children of those families, even if either they were symptomatic or asymptomatic, they were not being taken care of. So I started collecting, reviewing these issues, calling these families, extending the family trees, and going into the depth of the complexities of the disease, not just in the probat, which is the person that manifested first the disease, but also in the relatives, and especially in the young family members. And the complexity of Brugada syndrome is that it has an overlap of genetic expression. We know that there is one pathogenic gene, that is the SCN5A gene, that is carrying a variant that results in an abnormal sodium channel. And adults that present this gene, that the Brugada syndrome, have 30% of possibilities of having an identified gene mutation in this sodium channel gene. In children, when the disease is expressed very early, this yield of diagnostic tests goes up to 70%. However, we know now that just the genetic is not enough, that there is some other triggers that cause RVOT, right ventricular outflow tract inflammation, replacement by fibrosis, scar cells, and this starts to alter the junctions, the links between the cells. And this genetic background plus triggers that the individual encounter that could be viral infection. Sometimes we speak about vaccination, environmental triggers, or even medications, gives them a susceptibility to express clinically the disease. And once the patients start to express this abnormal ECG feature and pattern, we know that arrhythmias, ventricular arrhythmias, potentially life-threatening, are ominous. In children, fever is a very, very important marker because children are exposed to new infectious agents as part of their immune system growth and development, and this triggers inflammation, process of fever, modulators of the inflammatory response, and that we know nowadays that those triggers put together makes the underlying genetic susceptibility to express. And so we started to study this many years ago with the Shanghai criteria. This was a consensus of specialists in adult Brugada syndrome that gave baselines to diagnose accurately the Brugada syndrome. However, this only applies to adult patients. So there is a lot of knowledge, there's a lack of knowledge of how this disease expresses in early childhood. However, we know nowadays that in the severe cases where the children start to express the disease, from the onset of the disease to a potential little event, there could be a very short time. I started myself being interested in pediatric Brugada because I encountered during my first days working as a pediatric electrophysiology consultant in Belgium. I encountered a 7-year-old that presented to the emergency department in atrial fibrillation, and he was admitted to attempt a cardioversion, but they didn't want to put him under sedation to cardiovert him, so they decided to use oral amiodarone. And this is what happened after the bolus of first IV bolus, then followed by oral amiodarone, and this is what happened. He terminated the episode of atrial fibrillation, went into a very, very long pause. And after that, he presented the typical pattern of type 1 ECG. So in children that present with abnormal findings of atrial arrhythmias, atrial fibrillation, sinus node dysfunction, we should always have in the back of our mind that this could be the onset of a Brugada syndrome. And I shared this with you because this is not what many people would expect. Most cardiologists take Brugada as the disease of the adult life, and we are missing all these populations of young children that are expressing the disease very early in their lives, and that indeed could have very severe consequences and sudden cardiac death. So this is how I started to be interested in the disease, and I started working with Pedro Brugada in 2014 in Belgium, in Brussels. I completed my PhD with him and published a set of 8 papers on pediatric Brugada syndrome in 2017, and I presented initially this request and this interest to join effort through the community of the world electrophysiologists focused on pediatrics in the Pediatric and Congenital Electrophysiology Society basis in October 2017. I participated in the research meeting and proposed to start a prospective registry to try to understand more this rare orphan disease, but which at the same time have severe and profound impact in the health of children and families who are touched by the disease. So there was a huge interest by the pediatric EP community, and we started putting all the legal aspects together. And by August 2019, it takes almost more than 1.5 years, we finally got ethics for prospective registry of strains through PACES, and at that time from my affiliation in Europe. And we started data collection in a red cap on October 2021. And this is where I want to also thank SADS UK and this wonderful group of also patients and families that are based in UK and that supported our research as you in SADS US are doing. So we got a grant from first a year in 2021, which was extended to a second year. And this allowed us to build up the infrastructure to contact the centers, to pursue the database collection, and to set the basis for the registry. I have recently relocated 9 months ago from my affiliation in Europe to Montreal, Canada, where I'm now based. And we have been through the process of relocating the database to Canada. I also want to mention that in this process, HERO, the heart and rhythm, based in UK, has been a great asset and collaboration as it unifies all the Canadian pediatric centers. And we are collaborating through them as well to enhance the collection of pediatric cases in Canada and through American continent. So this is the situation of the registry as per today. We have 52 centers that are in the enrolling process. And because there are genetic bases and because the triggers are very varied and different, and we know that diet and environmental exposures are also a landmark that defines expression of the disease, mostly in the early age. We're trying to collect an international sample of patients, and this is challenging because, as you know, the world has many complexities and many different medical backgrounds, and many of the centers that are participating through Europe and United States are centers which have the infrastructure to provide ethical and legal support and that have processes already set to smoothly move forward through the challenges of sharing patient information. But many of the centers that are interested in participate come from more isolated regions, and this infrastructure is not present. So we're trying to provide support to these centers and walk through together through the legal aspects of the disease, of the enrollment. We have nowadays centers that have already completed the first set of data collection. This is a prospective study, and we are getting the information of the patients at enrollment and then yearly for a period of at least 5 years, probably to be extended for 10. And so 11 centers, no, 12 centers now started data collection, and we are now having 176 patients in the database as per the last days. But we are going through the challenges of getting all the centers to enroll, mostly getting IRB approval. And in the post-COVID era, there has been a gap of progression of some of the centers through the COVID era, and we are now restarting and moving forward with this. So we are trying to get a sample that is representative of the human race and the world population. Relocating from UK to Canada has caused some delay in the project, but we are now collaborating with my previous affiliation, University of Bristol, and with NHS and the Canadian resources, and we would also want to see more centers in the US enrolled. We are considering the possibility of providing an patient self-enrollment. So this is from our last presentation, and here is the way to contact us. This is my email. This is the telephone number to reach us. We can either enroll you through your medical center. We are now incorporating for more isolated areas also patient self-enrollment. We are trying to get a sample that could provide solid information on how this disease manifests in early life, indicators of ICD implantation and how to protect these children, but also what to do with those young patients which belong to families that have a diagnosis of adult Brugada, either with sudden cardiac death or implantation of ICD or ventricular arrhythmias, and who need an assessment, who need a screening, who need follow-up, and we have no scheduled way to propose this to the community. We as pediatric electrophysiologists face this on everyday basis. A subset of patients that come to us referred by adult cardiologists because there's somebody in the family that has a diagnosis of Brugada syndrome, and we need to make a plan with the family and share with them the risk of their children, and we don't have solid data to share or to risk stratify this second population, which are the children from families with the disease. So the registry will not only provide us with information on the individual risk of those children that have the genetic variant or that have expressed clinically pediatric Brugada syndrome, either by ECG or by arrhythmias, but will also help us understand what is the best project to manage the children that belong to families where there's an adult that has presented with sudden cardiac death due to Brugada or some manifestation of the disease by itself. So this is our aim. This has been my goal and my dream and challenge during the last years. There are many people that have been involved. There's a long list of centers all around the world, mostly in Europe, where this registry started and has been I have been networking and collaborated, but also through PACES, many centers now in US and also in Canada. The goal is to achieve and enroll at least 500 patients. I think that we will reach that goal in the next years to come. And I help. I call to your help and assistance to participate, to expand our research, and to showing if you have Brugada syndrome, somebody of your family has Brugada syndrome, we're already here to give you support through enrollment and assist you in either self-enrollment or getting in touch with your heart rhythm specialist to facilitate the process of enrolling you through your center. Thank you very much. I will leave it there. And if anybody wants to contact me, my contact is online. I'm always available. Thank you very much.
Thank you, Dr. Corcia. We do have a couple questions that I thought I'd go ahead and ask you quickly before we move on to the CPVT registry. One is from Christine, and she asks, in Brugada syndrome, is having sick sinus syndrome commonly associated with the SCN5A gene variant? Do you know any stats on this?
Yes, thank you very much. This is actually a very good question, and I can share my publications on this. I didn't want to be very extensive on our research, but mostly focus on what the patients could be interested. But we know now that in children, the most frequent early marker, children, young people, of Brugada syndrome is sinus node dysfunction. In the children, it can manifest as breath-holding spells. Sometimes the children start to cry, have a vagal response, and lost consciousness. But this is not the typical breath-holding spell. It's very profound, goes with seizures. Sometimes they have a loss of sphincters as well. And in children, these very severe events of syncope or breath-holding spells are a common marker of sinus node dysfunction. And they usually go together with atrial fibrillation or atrial arrhythmias. So this is a very good question that brings to light that the presentation of the disease in the first year of life is different and is pathognomonic by itself. So yes, this is the case. Thank you for the question.
All right, thank you very much, Dr. Corcia. I think we'll move on now to our second half of the presentation on the registries. And I want to introduce another Canadian, Dr. Sanatani. Dr. Sanatani is the head and division of pediatric cardiology and the medical director at British Columbia Children's Hospital Heart Center in Vancouver, Canada. So welcome, Dr. Sanatani.
Thanks so much. And thank you to all the North American SADS organizers who have put this together, and thanks for inviting me. I am going to try and figure out how to share my screen properly. So hopefully you are seeing a slide. Although
yes.
I don't. Is it the correct view? That's my greatest fear.
It was.
Excellent. All right. Yes. So yes, thank you. Thanks all. And thank you also to Danna Callis, who I think might even be in our audience today, who really
I saw her name. Yes.
has done all the work, including the slides for me today. So we'll just give you a update. I know we're a little behind time, so I'll try and move through things here. And nice to hear what Cecilia is doing in the Brugada space. And just a quick reminder, and I know we have a very educated audience, catecholaminergic polymorphic ventricular tachycardia, or CPVT, is a rare inherited arrhythmia condition. We estimate 1 in 10,000 people. Don't know exactly where that number has come from. And really the classic sign is, in fact, something called ventricular tachycardia. So when the bottom chambers take over the rhythm, and on the screen there, you can see a very typical exercise test. I'll try and activate a laser pointer, getting very technologically bold here. And so at the start, really everything looks very normal. And then with even just a little bit of exercise, this might be a brisk walk even, these different looking beats start appearing, premature ventricular complexes, which increase and become increasingly complex. And this up-down pattern is really one of the hallmarks, though not always seen. And then I'm always amazed at this. The child is still running here, but does sort of comment that they might want to stop running at that point. So the exercise test is really one of the key diagnostic tools. The mechanism we now know and have known now for 2 decades is a abnormality in what's called the ryanodine receptor. And this is what essentially controls heart muscle contraction. The ryanodine receptor allows calcium. Calcium are these little blue balls that move in and out of the heart cell to allow the very complex apparatus to contract. And that is a fascinating talk that we will have at some point. When the ryanodine receptor is normal, the function is as shown. When the receptor is leaky or has what's called a gain of function, the cell becomes loaded with calcium. And there are a few different theories about how and why this leads to the abnormal rhythms. And you will also have heard things already this morning about flecainide and stabilizing this ryanodine giant molecule. So a timeline not unlike Dr. Gonzalez. We started a little bit earlier. We're just past 10 years at this, and started really with how many PACEs, or Pediatric and Congenital Electrophysiology Society. Many of those initiatives are just someone sort of irritating, sending a lot of emails, and eventually a small group of people coming together and saying, yes, let's do this. And back then we were really looking retrospectively, so looking back at the patients we already had, and then we switched it over and have been collecting prospectively for about 8 years. So collecting data forward. Very important to mention that right from the beginning, we had a strong collaboration with the adult centers. We established some grant funding or we were able to obtain some grant funding to get the registry going. And the structure here is probably a little bit simplified through this. There is an overarching international PACES registry, an international CPVT registry that is led by Arthur Vilde and now is being taken over by Christian van der Werf, his protege. And this registry really contains all the pediatric and adult CPVT patients that are being tracked, which is a very substantial number, well over 1,000 people in this combination. And then we live within that in the International Pediatric Registry, or the PACES registry, and we struggle sometimes with the name. And you can see here there's lots and lots of people and centers to thank. The ones on the screen on the right are those mostly larger centers that enroll directly to the international. And of course, always a good time to shout out to Dr. Michael Ackerman, who is one of the leaders of course, he's a leader of SADS and also a leading enroller in these registries. So always nice to be part of something that he is putting together. And here's our map, almost the inverse of what Dr. Gonzalez showed. We have a lot of American centers and need to get a bit more international. So we'll have to have a talk, Cecilia, and get some collaborations going. I saw you had one down here in Australia. So we're at about 389 patients and their relatives. Most of them are patients, so I think a good 2/3 are patients enrolled. And we did have a little bit of flattening during COVID, and we're hoping to see that picking up. Currently, we're just finishing off work on our latest grant, which really had two components. One is looking at physical activity, and Danna just presented some preliminary data at the Heart Rhythm Society meeting, which I'll show you in a moment. And then what we're still working on and can really use the patient group help here is the quality of life in those with ICDs, or implantable cardioverter defibrillators. As some of you probably know, ICDs are often implanted in SADS conditions and then not always supported when one does see a SADS expert. So I have very few patients with ICDs in my SADS population. There are obviously times when they are very important and very well used, and there are also times when maybe we can have alternate therapies. Danna's master's thesis published this year was a very impressive look at really these young patients, because CPVT is primarily a condition of children with a median age of about 10 years old. Sometimes there's a delay in diagnosis. Certainly there's an adult form that is probably a little bit less typical. So certainly typical CPVT or classic CPVT is a pediatric condition. And here's just one of the large studies that we were able to do, again, by collaborating with our Amsterdam colleagues, looking at beta blockers, which are, of course, the mainstay of treatment. We've had quite a bit of interest in Thomas Roston's really very preliminary report, where we, rather than doing traditional exercise tests, had people essentially get on the treadmill and then do short sprints, which unmask some arrhythmias. So we believe that the type of exercise test and where it's done are very important. This is the abstract I was referring to that Danna presented just recently. And I think it was very interesting because, as many of you know and have lived through, the physicians are often very fearful of letting patients do things once they've been diagnosed with a SADS condition. And it's not always based on evidence. It's often based on fear, and sometimes fear of medical legal consequences, and mostly that there's no evidence. Mike Ackerman and his group have been very active in pushing back the boundaries of ignorance, and their paper by Ostby is the first author, was one of the first papers to say, definitely get your CPVT patients more active. It's safe. And Danna's data is showing very much the same. So we're excited to get more participants in that study and really monitoring. The sad side is, though, that almost all of our patients are not meeting daily recommended amounts of exercise. So we are becoming a bit lazy as a population. It's very important for me to mention a group that I have a real privilege of collaborating with, and that's my basic science colleagues. And really, in order to understand these conditions to the extent that we need to, and we're very rapidly moving into very advanced therapies, genetic therapies, and very specific molecular targets. I always feel like I need to go back to medical school to learn what we're doing now. So Glenn Tibbetts here shown on the stage. I just click on this link and hopefully it works. So that was some actual cells from a CPVT patient, which we can then use to study in a Petri dish and then eventually test molecules. And they're in the process of testing certain molecules on these stem cells. One of the somewhat unexpected learnings from the registry was the description of the opposite. I had mentioned a gain of function in ryanodine. So this revealed, of course, the loss of function. And some of you will be familiar that long QT type 3 and Brugada syndrome have this similar relationship, this seesaw relationship, where either you have a too much or too little. And so calcium ryanodine receptor, calcium release deficiency, CRDS usually, so it's not quite as much of a mouthful, is also something that we're learning a lot about and doing investigations on. It's much harder to diagnose. I just want to thank our many collaborators and supporters, and of course the SADS Foundation on both sides of the big border in North America have been very supportive of getting our patients involved and informed. And I want to mention a special cause that came into our lives last year, a Piece of My Heart Foundation, a lovely family who tragically lost their daughter to CPVT and have, like many of you, have turned their loss into real action and have been fundraising to support our work. So with that said, please get in touch with us if you want to be involved in our research. First, of course, talk to your specialist and encourage them to join our registry if they're not already in there, and always happy to take questions. So thanks very much.
Thank you so much, Dr. Sanatani. If there's any questions for Dr. Sanatani, please post those in our chat and we'll pass those along to him.
And I think they get another shot at me at noon my time.
That's right. In another hour, almost 45 minutes.
All right.
Right? Yes, about 45 minutes. Dr. Sanatani will join Dr. Ackerman and Dr. Tondri for our Q&A. So you can save your questions, think about them, and you can come back when he joins us again later. So thank you very much, Dr. Sanatani. We appreciate it.
Thanks so much.
Okay, next we have a presenter of Genetic Testing and You by Allison Cirino. Allison is a genetic counselor and an associate professor in the School of Health and Rehabilitation Services and the director of the student research in the genetic counseling program, the master's level program at MGH, Massachusetts General Hospital Institute of Health Professions in Boston. Since 2004, she's been a genetic counselor at the Brigham and Women's Hospital Cardiovascular Genetics Center, where she is involved in both patient care and ongoing clinical research activities in inherited heart disease. Allison will tell us more about genetic testing.
All right.
Welcome, Allison.
Thank you so much for the introduction, Marcia, and the invitation to participate in this conference today. So let me share my screen first. Get myself going here. Sorry here. Oh, got all the way back to the beginning somehow. Okay, here we go. Are you seeing that okay?
Yes, looks good.
Okay, great. On track here. Thanks again. So I'm pleased to talk to you this afternoon about genetic testing. So first, I wanted to establish a baseline and review two main overarching categories of genetic testing that you might have heard of and that I'll be referring to today. The first is diagnostic testing, and this is genetic testing that's used in a patient with a known or suspected inherited condition to identify the underlying genetic cause of that condition. And it is usually done with broader genetic tests that look at many different genes that have been shown that have strong evidence to suggest that they can cause the particular condition if the gene is altered in some way that makes it not work properly. Once a variant is identified from diagnostic genetic testing, it then enables a different type of test called predictive genetic testing. And this is genetic testing that's used in unaffected relatives to determine who in the family has inherited the DNA variant and therefore the risk to develop the condition. And this is a test that looks specifically at the DNA variant that was already identified in another family member. So it's a very focused type of genetic testing that we do. So with this in mind, I wanted to first talk about, how genetic testing can be helpful. And we'll start by talking about how it could be helpful in patients. So again, thinking about this diagnostic genetic testing. So we can think about the utility of genetic testing in three main areas: diagnosis, prognosis, and therapy. So the image on the right of the slide is taken from recent joint consensus statement guidelines, and each plus sign corresponds to an area where there is some evidence to suggest that genetic testing can have a useful impact in that area for that particular condition. So for diagnosis, we know that it may help us to make sure that we do in fact have the correct diagnosis based on the symptoms that are presenting in an individual. So it can help us also to rule out other things that may have overlapping symptoms or features. And this can also be valuable when we think about using it for postmortem genetic testing when people are seeking an explanation for sudden death. For prognosis, in some cases, it can help a genetic test, a particular variant can help to predict the severity or other outcomes that could be expected, which can then be used to guide management and make more tailored recommendations for a patient and family. And then lastly, with respect to therapy, there are situations where genetic testing might help to determine which treatments would be most effective and which interventions should be considered for a particular condition. So as you'll see on the top here, long QT syndrome is one for which we have a number of different plus signs across these three categories. So I thought it might be useful just to highlight that as an example. So when we're thinking about long QT syndrome, we know that genetic testing can help to confirm that a person has, in fact, an inherited cause for their prolonged QT, which can be helpful for them, but also for what it means for consequences for their family, implications for their family members. And it can also help to define the particular subtype of long QT syndrome a person has, like long QT 1 or 2, et cetera. For prognosis, we know that there is some evidence to say that certain variants or variants in particular areas of a gene can be associated with more mild or severe presentations. So that can help with, setting expectations and, predicting which types of surveillance, et cetera, might be necessary in a particular case. And with respect to management, this ties back to the idea of the value of defining the subtype of long QT syndrome, since there are specific subtype-specific management considerations based on information that we know about the subtypes, such as what things are more likely to trigger arrhythmias, which can lead to recommendations for certain lifestyle interventions, as well as how effective particular therapies might be, like beta blocker or left cardiac sympathetic denervation, and when to consider the use of an ICD. So we also know that caring for a patient with an inherited condition includes addressing the implications for that patient's family members. So I want to think about also how genetic testing is useful for family members. So most inherited arrhythmic conditions follow an autosomal dominant inheritance pattern. So as a reminder, this means that for every affected individual, there's a 50% chance that they could pass the disease-causing variant in risk for the condition onto each of their children. So with that in mind, we know that has implications for a family. It means that there may be a number of individuals who are identified at being at risk and are now have management recommendations as a result of that. So if we think about how we can use genetic testing to kind of tailor this process a little bit, I will use ARVC as an example here. So the picture on the right, this figure is taken from the 2019 ARVC consensus guidelines. And it starts at the top with a process that we often use is gathering family history. So you'll see there a pedigree. So males are squares, circles are females. And what we're trying to do there is use this as a tool to identify who in the family is actually at risk. So in their figure, that's depicted by asterisks inside the shapes. I also put them in a red square to draw attention to them a little bit. So these are individuals who'd be felt to be at risk for ARVC just based on their position within the family. So then when we have at-risk individuals for ARVC or any other inherited condition, there are going to be a set of recommended evaluations that they should undergo to explore whether or not there are any signs or symptoms of that condition. So and these are often things that are, they may be started at different ages in life, but are often periodic and longitudinal over the lifespan to continue these evaluations. So it's advantageous to think about ways that we can more refine who is actually at risk or not. And this is a way that we can use genetic testing. If there is a known variant in the family, we can use genetic testing in this process to determine who really does need to continue to undergo those future evaluations and who can be excused from the need to continue on with that longitudinal evaluation, which can be very helpful in a family. So if we take this all together and think about the role of genetic testing, again, we can think about starting with the person who is suspected to have a condition and do diagnostic genetic testing. So if we identify a variant, that then can help us to confirm that person's diagnosis and tell us why it happened, and may also lead to some impact on their medical management, though admittedly not always. But perhaps an even more valuable use of the genetic testing can be how it can be used in the family for predictive genetic testing. So again, if we have the variant and somebody in the family tests negative for that, then they can be reassured that they're not personally at risk to develop the condition in the future, nor are any current or future children that they might have. And so all of those individuals would not be required to undergo any type of longitudinal surveillance. On the other hand, if somebody tests positive for a variant in the family, it tells us that that person is in fact at risk to develop the condition and needs to undergo, the longitudinal surveillance. They also have a 50% chance to pass it on to any of their children. And so, and there are also some other considerations that they might be able to think about in a more proactive manner, such as are there appropriate lifestyle modifications, perhaps exercise restrictions that would be appropriate, or other life planning decisions like reproductive planning or getting the types of insurance in place that they might like to have in advance. So it can be helpful for future planning for individuals, even if they're getting a result that is not the result that they hope to get. So I wanted to touch a little bit again on the what I just mentioned, a reproductive planning option, because this is certainly a use of genetic testing. So pre-implantation genetic testing is a reproductive technology that's been around for quite some time now. In order to do it, it does require that we know the known variant in the family already, and it does require the use of in vitro fertilization to create embryos that can then undergo testing themselves. So the embryo themselves undergo genetic testing. Embryos that are found to have the variant are not used further in the process for implantation. Rather, the embryos that test negative for the variant in the family are used for implantation to initiate a pregnancy. And then this is typically followed by additional prenatal diagnosis, either with amniocentesis or chorionic villus sampling, just to confirm that in fact the pregnancy is not impacted by the variant. So this has a highly personal decision about whether or not this is something that somebody wants to do, but it is a technology that's out there, is being utilized for, a growing number of inherited conditions, including inherited cardiovascular conditions, as a way to try to prevent the transmission of the condition from one generation to the next. So it's important for people to know that it's out there and available if that's something they would like to learn more about and to consider. So when thinking about what the genetic testing process looks like, as an overview in basic terms about what one should expect, it should start with a thorough pre-test genetic counseling conversation so that people are making an informed decision about whether or not the genetic test is right for them at this particular point in time in their life. If they decide to move forward, we collect samples, typically blood or saliva samples, that are then sent off to specialized genetic testing laboratories that run the tests and do the analysis of the results. Those results then get sent back to the provider who ordered the test, where they are reviewing it themselves or with their team to come to a consensus about what the results mean for the particular patient for whom the test was ordered. And then a discussion occurs between the patient and the provider about what the results mean and the implications for them and their family. And then there's a discussion about sharing the information with the family members. So to get into it a little bit more about what is included in pre-test genetic counseling, this is a conversation with the provider, ideally somebody who has a lot of experience with genetic testing and can, provide all the necessary details for decision making. We're often reviewing the family history, as we looked at with the pedigree on a prior slide, to understand who's at risk, and also to make sure we're starting the testing process in the family with the best person. We want to typically start the testing process with somebody that we feel we have the highest level of suspicion has an inherited condition. We're reviewing what the recommended genetic test is in a particular case, because sometimes there are decisions about how, different tests that might be options, like smaller tests, larger tests that we're deciding on, which is appropriate to use, discussing the benefits and limitations of testing, and reviewing a number of different test logistics like cost, acceptable sample types, and the turnaround time, so that everybody's on the same page about the logistics that are part of the process. So there are some things that are important to consider when people are deciding about testing. And one is that we don't always get a definitive answer from genetic testing. We don't always have a complete understanding about all the ways that our DNA can lead to disease. So there can be some ambiguity that comes out from genetic testing, and some people just don't do well with ambiguity. So that's something to consider when going into the process. While we talked about ways that the genetic testing can be useful, it doesn't always allow us to make any predictions about what to expect for a given patient, or allow us to make treatment decisions based on a particular result. So there are certainly instances where somebody who already has a diagnosis may not experience any meaningful change in their kind of day-to-day medical management, but again, it still could be useful for the family. There are also a range of emotional reactions that people can have to the testing process and test results. People can experience negative emotional reactions like fear, anger, sadness, and guilt. These findings can emerge in people with positive or negative results. Thankfully, in most cases, the negative psychological reactions to testing do not last or persist over time. The testing process or results themselves can worsen existing tensions in families or create new ones as individuals make decisions about make different decisions about whether or not to pursue testing, or if multiple people are tested at the same time and get different results. It also can be challenging for parents or parenting couples to make decisions about whether or not and when to test their children. And lastly, in some circumstances, there is the potential for discrimination with some types of insurance. So I'll touch on that. There had long been concern about whether or not undergoing genetic testing as an unaffected person, is putting that into your medical record something that would pose a risk of discrimination for you. So a number of years ago, there was a federal law passed called the Genetic Information Non-Discrimination Act, abbreviated GINA, and this provides federal legal protections against the misuse of predictive genetic information in the areas of health insurance and employment, so that it can't be considered as a pre-existing condition and used for like insurance underwriting, and can't be used for employment-based decisions. However, there are not the same federal legal protections for things like life insurance and long-term disability or long-term care insurance, though there are some state-to-state regulations. But so there are some limitations with what this covers, including the fact that it is not applicable for people who already have a diagnosis, and some other groups like people in the U.S. military or those who may work for very small employers who are not beholden to this federal law. So it's something that people need to consider when they're unaffected people going through testing to make a decision about whether or not this is something that's, worrisome enough to them. And, if they're adults who want these types of insurance and just haven't gotten around to them yet, some people just decide to do that before proceeding with testing. So when we're going through the process, we want to think about what are the types of results we can get back. And they fall into 3 categories. So a negative result from a diagnostic genetic test means, that we did not find a clearly disease-causing change in the DNA when we looked at a bunch of different genes that can cause this condition. So it's kind of an unsatisfying answer because it doesn't rule out the chance that there's a genetic cause. It just means that we can't find it based on our current available tests. It does, however, mean that when we didn't find something with that test, we don't have a way to do predictive genetic testing in other family members, because if we didn't find something in the first person, we don't have something to test the other people for. Sometimes we get an unknown or uncertain result. And this happens when a DNA variant is identified, but there's really not enough information available to determine with confidence whether or not it's the cause of disease. Sometimes we can do additional testing of select affected family members to see if the variant tracks along with the disease in the family, and that can shed some light. But sometimes we're left in an ambiguous state. And when that's the case, we generally don't recommend using that variant for predictive genetic testing. And then lastly, sometimes we get a clear positive result, meaning that for this variant, there's enough evidence to say that it's the cause of disease in that person. And that's something that we would typically feel more confident using in other people for predictive genetic testing. So when you're kind of thinking back about these steps in this process, an important part of it is discussing the results with your provider. And in the course of that discussion, you'd be talking about what, if anything, was found, which of those categories of results came back, how confident are they that anything that was found is the cause of disease in your case. Again, unfortunately, it may not be a clear yes or no answer sometimes. And this conversation will also include a discussion about what are the implications and next steps for you and your family, including whether or not this is something that people would feel comfortable using for predictive genetic testing in the family. As you might imagine, we want to use a pretty high bar for that and make sure that if people are using this information to predict their risk of disease and potentially be excused from ongoing screening, we want to be as sure as possible that we really have identified the cause of disease in the family before doing that. And so, and that leads to this part, which an important part of this process is to make sure that you're sharing information with your family. Your diagnosis, your genetic test results may have impact on other people in the family. So you can talk with your providers about the ways, like what information is helpful to share with them. And maybe, sometimes people have templates for letters that can be provided to family members and such. And keep in mind that if you do go through genetic testing and have something found, your genetic test report itself contains all the information that a family member would need to bring to their provider in order to order genetic testing in them. And then I want to put in a final plug to make sure that you're staying in touch with whoever orders your genetic testing. And this is because information needs and knowledge can shift over time. What you need to know might change over time. Maybe you're tested at an earlier point in life and, reproductive planning or testing children are not on your radar at that point. But then, fast forward into the future, you may be thinking about these things and you want to make sure you have the most current information before making any decisions. And then sometimes we get updates about genetic testing as knowledge shifts over time. So it's good to remain in contact to make sure that you're always kind of operating with the most up-to-date information, and also whether or not there's any additional genetic testing that could be considered. And this might be true, say, if you're somebody who went through testing quite some time ago and had a negative result, it's fair to ask whether or not there's a more current version of the testing that might be appropriate to consider. So I'll end with 3 key messages. First, genetic testing can certainly provide valuable information in some cases to patients and families, but this is an individual decision that needs to be made after thorough discussion with experienced providers. And because of that, this whole process is best done with a specialized team that can give you, the right guidance and support throughout. So I will end there and take any questions. Thank you so much. Yeah. I don't know if we have.
Thank you so much, Allison. We do have a couple questions already.
Yeah, I see one in the chat about the genetic testing of embryos, the pre-implantation genetic testing. So, as with many things, the insurance coverage discussion around that is a little bit variable, but there certainly are instances where people's insurance can cover the IVF piece, the pre-implantation genetic testing piece, or both of those. So we do always send any patients of ours who are interested in pre-implantation genetic testing onto a team that can help them have a detailed discussion about what they can anticipate for any out-of-pocket costs, and also to review the process, because it can actually be a relatively lengthy process. So people want to know what they're getting into. But there certainly are circumstances where people have the entire thing covered, but not all.
Okay, thank you.
Yeah.
Elliot also asked, he has Brugada, and he was wondering at what age should he have his daughter genetically tested? She's 7 and has no signs on an ECG of with or without fever.
Yeah, this is a great question. I mean, obviously, kind of the first thing for any of this depends on whether or not the affected individual, or the parent, or Elliot, I guess in this case, we could use as an example, has a clear disease-causing variant that's causing Brugada or any other condition in that instance. That's, the kind of critical piece first, like how confident do people feel that they've landed on a cause. And then when it comes to thinking about testing children, there are a lot of different approaches, but a common approach I see is to think about, like, for the condition, when would people say that you should start screening this child? And when might they need to start engaging with, like, the medical system, or when, what is the typical age of onset of the condition or initiation of screening? And at that time, it's worth a conversation about, is it, do we consider the genetic testing at this point, because then it would help steer whether or not any ongoing screening like that is necessary. But the caveat also is that, some people do certainly decide to wait for ages in which the childs themselves can be engaged in the discussion. And so there is a lot about the individual child that gets factored into this, and, the extent to which you are ready to engage them in a conversation. Somebody collecting samples, blood samples, follows questions about results. So I think I always encourage parents to kind of think through all the steps about what comes after the genetic testing, and are they, ready to have the subsequent conversations about what that means with their children.
Okay, thank you.
Yeah.
Ruth asks, are there considerations to integrate SADS conditions into newborn screening?
Oh, yeah, that's a great question. Yeah, I think I've certainly heard conversations about, newborn screening and or just kind of like population screening in general for inherited heart conditions. So there are lots of considerations that go into decisions about what's appropriate for newborn screening. And a lot of it would be like, how common is it in the population, and how often do things happen in childhood, and are there clear interventions that would happen in childhood that would make it advantageous to know as early as possible whether or not this is something that one should know at birth, because that needs to be balanced against the fact that newborn screening, as well as like genetic testing in newborns and babies, does to some degree take away autonomy of that person to decide whether or not this is something that they want to know about. So that it's always kind of balanced about what's the value of knowing the information at that point in time before deciding that that's something that should be a kind of global screening recommendation like newborn screening.
Okay, excellent. I don't see any more questions in the chat right now. Oh, there's one. My 21-year-old son has long QT. His EKGs are relatively normal. He has never had an event. However, let's see, long QT1 is on his medical chart. Is this going to prevent him from entering the military?
Yeah, this is a good question. So the military, there are certainly people who are active in the military with inherited arrhythmic and other inherited cardiovascular conditions, but it ends up being, in many cases, a kind of more customized and kind of tailored discussions that includes like the individual, what the condition has looked like in that individual, in ways like the potential risks to the individual, and depending on their role in the military, the risk to other people, because sometimes the consequences are not just to the individual in the military, but to other people who would be impacted by, sudden abrupt loss of consciousness, for example. So I think it's not a uniform yes or no answer, but it is something that one can expect would probably be, if it's in the medical record and is appropriately disclosed, will undergo some degree of scrutiny by the military to figure out whether this is something that would impact overall ability to be in the military, in addition to that, potentially what role one could take on. Okay. I'm sorry, Marcia, I don't know if we need to move on. I can also answer this, and then if you want me to stop answering questions, I'm happy to answer in the chat.
If you want to answer this one real quick, and then
okay, yeah.
Well, this will be our last one.
Yeah, so many insurance policies actually see the value of predictive genetic testing. That math works well for insurance companies, because if you're saying this person would need to undergo longitudinal screening with, whatever it is, maybe echoes, EKGs or whatnot, they see the value often in paying for a predictive genetic test in that individual, in order to identify those individuals who don't need to go on with screening. So that typically we have success with getting it covered. In some cases, the diagnostic testing is more variable, because insurance companies don't universally agree that there is added value for that particular patient and how it's going to change their management. And they don't operate under a model where they view the impact to the family as being part of the math about whether or not it makes sense for them. But usually providers are able to kind of justify this and try to get coverage. And many genetic testing companies also have programs in place that can cap out-of-pocket expenses for people. So I always encourage people to have a current conversation with somebody about cost, because it can certainly still be a barrier, but sometimes it's not as big a barrier as people think it's, big a cost as people think it's going to be.
All right. Thank you very much.
Yeah, thank you
so much. We got through it all in your limited time. Very good. So we appreciate you, Allison, sharing part of your Saturday with us and talking to us more. So,
all right. Thank you.
Take care. Okay, next we have another Canadian who is Dr. Danna Spears, who is an electrophysiologist in the Division of Cardiology and the Department of Cardiac Electrophysiology at the University Health Network in Toronto, Ontario, Canada. She's the clinical director of the Heritable Arrhythmia program at the University of Toronto. And we're lucky to have her today while she takes some time away from her vacation with her family. She'll tell us more about pregnancy and SADS conditions. So welcome, Dr. Spears.
Thank you. Thank you. I'm just trying to figure out here I'm just looking for my
share screen
PowerPoint presentation here. Okay, so I have my PowerPoint up. I apologize here. I'm just trying to.
You're okay.
There we go. Okay, so can you see that? Or am I sharing?
There you are. Yes, that looks good.
Okay, perfect. Well, thank you for the nice introduction, and I'm more than happy to be here. I didn't like the idea of just sending in a pre-recorded video, so we'll get right into it, and we'll talk about some of the inherited heart conditions that I see commonly through our special pregnancy program at the University of Toronto. So we'll start with long QT syndrome, which I think at this point, most of us are aware of what that is. And as you know, there are many subtypes and counting, but what I'm going to be discussing primarily are the most common subtypes, long QT type 1 and type 2. And as you may be aware, these subtypes all share a common phenotype or clinical picture, which is of baseline QT prolongation on some electrocardiograms and potential risk of arrhythmia-mediated fainting, or even worse, cardiac arrest and sudden death. So back in the late 90s, on reviewing the literature in long QT syndrome, it became apparent that women with long QT syndrome had a higher risk of events. And by events, I mean fainting or cardiac arrest or sudden death. A very small increase during pregnancy, but there was a substantial rise in the postpartum period, which is about 9 months postpartum, in the risk of dying suddenly or having a fainting event. And this was particularly important because this group, they were looking at the first event that happened in pregnancy. So these were women who had a diagnosis of long QT syndrome, but no events at all prior to their pregnancy. So we would consider these women to be pretty low risk, and that they had a 9% risk of an event in the postpartum period. The good news after looking at this data in the late 90s was that it was found that beta blockers were extremely protective in preventing these sudden death or fainting events in the postpartum period. So looking at the numbers, the risk of having one of these events after delivery was about 1 in 50 in women who were not taking a beta blocker. And that was reduced substantially to about 1 in 2,500 when you were taking a beta blocker. Sadly, in this population back in the late 90s, this message wasn't as clear as it is today, and only about 20% of women were actually taking a beta blocker. About a decade later, we began to understand more about the genetic mutations that were causing long QT syndrome, and it became apparent that the genotype had a significant influence on your risk of having an event postpartum. And so you can see here that the high rate of cardiac events is dominated by women with the long QT type 2 subtype. I don't know if you can see my mouse here, but this pattern remained in terms of postpartum events, both in women with long QT type 1 and also in women who either did not have genetic testing available to them, so they had a diagnosis of long QT syndrome without genetic testing, and women who had genetic testing, but no pathogenic gene mutation was identified. So in clinical long QT syndrome, it's very clear that postpartum is a particularly high risk for events in women with long QT syndrome. But again, looking at more contemporary data, it was still clear that beta blockers were reducing the risk of postpartum fainting or sudden death by more than 4-fold. So you can see here, looking specifically at postpartum, the blue is women who were not taking beta blockers after delivery, with a much higher event rate of almost 4 events per year when they looked at annualized data, with a significant reduction in these life-threatening events after delivery. And so this raises an important question where, you know, you may have a sister or a daughter or a friend who has an abnormal electrocardiogram. And the question is, what do I do with someone who has an electrocardiogram where the QT interval is borderline, or it's not quite clear, or they had a fainting episode, and in the emergency room, the electrocardiogram wasn't quite normal, and long QT syndrome is suspected. So in these women, when they come to me in pregnancy without a clear diagnosis, it is very important to make that diagnosis. And so my practice and the practice in our special pregnancy program is to look at a low-grade exercise stress test to evaluate QT dynamics immediately. And so what we're looking for is for the QT interval to shorten as the heart rate is increasing. And that's very important for, for the phenotype of long QT syndrome, because many people will have kind of a funny looking baseline electrocardiogram, but with exercise, the QT interval behaves normally and shortens up. And in that case, I'm very reassured that I'm not dealing with congenital long QT syndrome, and I'm not going to, initiate beta blockade and further testing during that pregnancy. I may look at them postpartum again, just to be sure, but I'm very reassured by a normal exercise stress test. If it's borderline, so we may have cases, particularly late in pregnancy, where you can see some natural, very minimal QT prolongation, but the T waves can look a bit off. And on the stress test, we may not see as robust QT shortening as one would expect. In those situations where I have a suspicion that I might be dealing with a long QT patient, then I will have a discussion about starting a beta blocker for that postpartum phase, so for up to 9 months postpartum, and then look at their electrocardiograms. And if we're seeing very abnormal electrocardiograms with QTs over 500, then I think the diagnosis can be pretty clear. But what I will do in cases where I'm still questioning it then is withdraw the beta blocker and repeat a maximal exercise stress test and look at QT dynamics. And again, in that case, they're either normal and I'm very reassured and the patient moves along, or we make a diagnosis of very abnormal QT dynamics and initiate beta blockade, genetic testing, and then that's when we would start triggering family screening, and especially screening of that newborn or young baby if we do have a diagnosis of clinical long QT syndrome. And so the importance of prenatal screening for long QT syndrome can't be emphasized enough. And something that I think that is overlooked is that in long QT syndrome, we can also reduce perinatal intervention when we identify a long QT fetus. During pregnancy, bradycardia or very low heart rate, we typically will look at as a sign of fetal distress. There's something wrong with blood flow, the placenta, this pregnancy is at risk. However, in long QT syndrome, low heart rate can be a manifestation of that genetic heart disease, and that can potentially flag a pregnancy that needs to be followed a little bit more closely, and a fetus that may be at higher risk of long QT complications. And so it's really important that we're engaging in that screening and looking at the fetus as well when we make a diagnosis of long QT syndrome in a parent. In addition, in certain genetic subtypes, the severity of the long QT syndrome clinical picture can be predicted by the heart rate. And so we've actually had in our center some really astute obstetricians who identify a fetus with a heart rate, 110 beats per minute is what we use as a cutoff for a very significant fetal bradycardia. And that has actually triggered a diagnosis in a family of long QT syndrome when this has been identified. But also that is a marker of a higher risk fetus where we should get a neonatology involved at the time of delivery because of the risk of arrhythmias and heart block and bradycardia in that newborn. And when we're also engaging in prenatal screening, we're anticipating the recommendations for getting a newborn electrocardiogram, discussing cord blood testing prior to delivery, and also considering cascade screening in case this is a new diagnosis. We look at other siblings within the family and extended family members of a woman who's pregnant and has a suspicion of long QT syndrome. So it's really important to start looking at this prenatally as well, not just in terms of looking after mom, but also looking after this newborn that's coming along. So to give a quick summary here, in long QT syndrome, beta blockers are absolutely indicated for arrhythmia prophylaxis. I recommend them as soon as the diagnosis is made so that we can get a stable and acceptable degree of beta blockade to protect our new mom postpartum. In terms of telemetry, and I'll discuss what telemetry is in just a second, but this is a special type of heart monitoring, which we recommend in labor and delivery if there's a history of arrhythmia. So if mom has had a cardiac arrest in the past, or their QT interval is in a high risk level, and typically that cutoff is about 500 milliseconds, where we start appreciating a higher risk for arrhythmia events postpartum. It's also critical to avoid QT prolonging medication. So sometimes this is the most life-saving recommendation that we make in long QT syndrome, is to be aware of medications that may put you at risk for potentially life-threatening arrhythmias. We also initiate genetic testing that can assist not only with family screening, but also in neonatal screening and also cord blood testing, which was just discussed, which is a really important part of caring for these women and new babies with long QT syndrome, and also to initiate neonatal screening. So I do recommend that when long QT syndrome is present in a family or suspected in a neonate, that they get an electrocardiogram prior to discharge to identify particularly high risk newborns who may benefit from beta blocker prior to leaving hospital. So what is cardiac telemetry? So cardiac telemetry is a special type of monitoring, and you can see here, these are the leads that you wear, and there's a little box here that transmits your heart rhythm to the cardiac telemetry unit. So you can see here, this individual is monitoring almost 50 individuals with their heart rhythm throughout the hospital. So this little telemetry pat can transmit your heart rhythm to a central monitoring unit, usually in the intensive care unit or the cardiac care unit, so that in certain arrhythmia conditions, if we're suspecting life-threatening arrhythmias in labor and delivery, the telemetry nurse and the doctors in the telemetry unit can pick up arrhythmias as they're happening prior to symptoms developing and prior to anyone being aware of it in the labor and delivery room. So this is how we monitor higher risk individuals during labor and delivery. So when I'm talking about telemetry, this is what I'm talking about. It's almost like wearing a Holter monitor during your labor and delivery. Okay, so then we'll move on to Brugada syndrome in pregnancy. And the good news is that in a review that was done, it's been almost 10 years ago now, but they had quite a number of pregnancies with Brugada syndrome, and found that the event rate was not increased during pregnancy. So this is really good news for families with Brugada syndrome, that this is not a time that you really need to be worried about event rates and cardiac arrest. Syncope or fainting outside of pregnancy is a big red flag for us. So that's a marker of a high risk for future arrhythmia events or sudden death if it's felt that that faint was mediated by an arrhythmia. We know that fainting is not uncommon in pregnancy due to blood pressure changes and volume changes and pressure on the vena cava. So women faint during pregnancy. The good news is that fainting in pregnancy is not a red flag in Brugada syndrome. And so that does not mean that you need to have a defibrillator. It does mean that you need to be evaluated by your cardiologist, for example, but it's not a big red flag like it is outside of pregnancy. There have been no reported arrhythmic deaths during pregnancy or labor and delivery in Brugada syndrome. However, on reviewing the literature, there has been one sudden infant death with Brugada syndrome. The significance of this is not clear. So when you're dealing with one event, it's hard to draw conclusions about the reproducibility of that in a larger population, but it does highlight the importance again of family screening. And so this discussion around genetic testing of a parent who is affected with Brugada syndrome, which can lead then to cord blood genetic testing. We do recommend ECG screening of the infant, just in case we can pick up a diagnostic Brugada pattern on an electrocardiogram. However, if the diagnosis still isn't clear, then we still are recommending that that infant is having aggressive fever management to avoid that provocation for arrhythmia in Brugada syndrome, and also avoiding sodium channel blocking medications, which can trigger arrhythmias in this condition, until they can be formally screened as they get older through a pediatric inherited arrhythmia program. Other suggestions for managing newborns in a family with Brugada syndrome really vary by center and also by country. So I've seen different recommendations, through Europe and through North America about having, for example, an AED at home. That is not something that is recommended through our inherited arrhythmia program, but I have been part of other arrhythmia programs where that is something that they discuss with families, to have something like this at home in the event of an arrhythmia in the newborn. So some summary statements here about Brugada syndrome in pregnancy. An ICD is indicated if there is a personal history of cardiac arrest or syncope that is felt to be because of an arrhythmia. So an unprovoked syncope would be an important red flag in Brugada syndrome, where we may discuss having an implanted defibrillator. Genetic testing can be useful to assist with screening both of the neonate and other family members, and can also lead to being able to do some cord blood testing if that's something that the family would like to consider. I recommend telemetry in labor and delivery if there's a history of arrhythmia. So if there's a history of cardiac arrest in the pregnant woman, or if she has a spontaneous Brugada pattern, I will recommend cardiac telemetry during labor and delivery. Vaginal delivery is not contraindicated. So there's no reason from a cardiac perspective, to think that you need to have an instrumented delivery or a cesarean delivery. So there's no problem with having a spontaneous vaginal delivery in this type of condition. Something that's really important, though, is the drugs that are used for anesthesia during labor and delivery. Many anesthetic agents are sodium channel blocking drugs. So this is important to flag for the anesthesia team who will be managing a labor and delivery. And in this case, we recommend minimizing the dose and duration of exposure to the sodium channel blocking agent, and also some ECG monitoring. That doesn't necessarily mean to be cardiac telemetry, but electrocardiogram at baseline. And if, for example, with an epidural anesthetic, if higher doses of sodium channel blockers are required, then to be looking at the electrocardiogram for signs of ST segment changes, which may lead to future arrhythmia instability during that admission. And that may trigger a need for cardiac telemetry. In terms of screening a newborn, arrhythmia complications in neonates and in very, very young children are fairly rare in Brugada syndrome. And so I will recommend an electrocardiogram at baseline for that newborn, but then ongoing follow-up through a pediatric inherited arrhythmia program should be considered. But again, the risk of developing complications at a very young age is uncommon. And so I generally advise my patients to not panic if they aren't getting into an inherited arrhythmia program for screening immediately, because really the risk is extremely low, unless, of course, there are clinical manifestations and presentation to a pediatric cardiac center early on. But in general, that's a fairly rare issue in newborns. So we'll talk about arrhythmogenic right ventricular cardiomyopathy in pregnancy here. So this is another one of the inherited cardiomyopathies that have a higher risk of life-threatening arrhythmia. So I'm speaking more from an arrhythmia perspective, but also this is one of the conditions that's close to my heart. So we follow this very frequently during pregnancy. One of the more recent reviews of women going through pregnancy has come out of Scandinavia, where they looked at a series of women who are ARVC gene carriers. So they have an established mutation in one of the ARVC genes. And these are women who may or may not have had clinical findings. So as many of you know, you may carry a gene that predisposes you to developing one of these cardiomyopathies, but not everyone will manifest changes associated with that gene. So those are the asymptomatic gene carriers. And so I'll be talking about those individuals a little bit in this talk. So the reassuring news that came out of more recent registries and reviews of these patients is, first of all, the number of completed pregnancies is not associated with subsequent arrhythmia risk in ARVC. So I have a lot of women who have been told that they can't have a pregnancy because it will put them at increased risk for complications down the road, or that pregnancy is a very high-risk pregnancy. And in most cases, that's simply not true. In this study, they looked at women who were studied a year after their last childbirth. So this was in the acute recovery phase after their delivery, and there was no increased risk in terms of arrhythmia in that time period. Then they looked also at women who were older and who were a little bit more distant from their time of delivery. And again, there was no signal that there was an increased arrhythmia risk in these women after completing a pregnancy. They also looked at parameters of the right ventricle. So they looked at arrhythmia complications, then they looked at failure, essentially, of the right ventricle and whether pregnancy was going to lead to worse heart function outcomes over time. And what was very interesting in this study was they found that the degree of change in the right ventricle, so dilatation or function of the right ventricle, there was no difference between women who had never had a pregnancy and given birth to those women who had at least had one pregnancy and given birth one time. So there's no indication here and in other registries that one or multiple pregnancies will have any impact on the function of the right ventricle over time. Then they also looked at women who were gene carriers but had normal imaging, so a normal echocardiogram or MRI, who had a normal electrocardiogram and who did not have any arrhythmia. So these are silent gene carriers. And these women were also found to have no increase in arrhythmia, no changes in their right ventricle, and pregnancy did not seem to have a negative impact on their cardiac function after having a pregnancy. So the message that I'm trying to send here is that events during pregnancy and delivery and postpartum are very uncommon. Ventricular arrhythmias tend not to increase. So if you look at someone prior to pregnancy and look at their arrhythmia burden prior to pregnancy, during pregnancy, and after, there did not seem to be any significant difference. However, women who had been on a beta blocker and who stopped their beta blocker for their pregnancy tended to have a higher risk of arrhythmia during that pregnancy. Heart failure has been documented in about 2% of pregnancies on review of many cohorts of arrhythmogenic right ventricular cardiomyopathy in pregnancy. However, these women tended to have a higher rate of major structural abnormalities prior to their pregnancy. So women who had severe right ventricular dilatation or failure of the right ventricle tended to run into more troubles during pregnancy. And so the message here is that the vast majority of women are fairly low risk prior to their pregnancy, and they remain so during pregnancy and postpartum. Women who have heart failure and a high burden of arrhythmia, especially those who are not well managed with beta blocker prior to pregnancy, are also those who are going to have a higher risk of events during their pregnancy or postpartum. But overall, it's incredibly reassuring for women who have this condition to be able to be optimistic about completing a pregnancy safely. Worsening of change in the right ventricle size and function during pregnancy is very rare. Beta blockade is absolutely indicated for arrhythmia management in women who have arrhythmia. So there are many women, again, who carry the gene, and some will recommend beta blocker for anyone who has any signs of changes within the right ventricle or a little bit of arrhythmia that is documented prior to pregnancy. However, I'm not recommending beta blocker in women who have no evidence of heart failure or arrhythmia prior to their pregnancy, and I'm not recommending beta blockers for women who are gene carriers without any manifestation of disease. That being said, I do follow these women fairly closely during pregnancy, usually once every trimester, to make sure that we're not seeing any changes at all, and to identify those women who may be higher risk. And also, cesarean section rates are no different from the general population. And so a woman with this type of cardiomyopathy, there's no reason to think that you can't have a spontaneous vaginal delivery at your local center. However, cesarean section may be recommended if you have heart failure or if you have poorly controlled arrhythmia during pregnancy, because there is evidence that cesarean section can be safer for women with advanced heart failure or poorly controlled arrhythmias at the time of their delivery. Overall, in arrhythmogenic right ventricular cardiomyopathy, a defibrillator is indicated if there's been a history of cardiac arrest, severe ventricular dysfunction or heart failure, or if we're picking up higher grade ventricular tachycardia on Holter monitoring or telemetry. Genetic testing is important, again, to assist with family screening and also screening of that newborn with cord blood testing, if that's something that a family is interested in. An unassisted vaginal delivery is not a problem if the right ventricular function is normal. And again, I'm speaking from a cardiac perspective. So, different forms of delivery may be recommended for obstetric reasons or for if there is fetal distress, but from a cardiac perspective, an unassisted vaginal delivery is not a problem. I recommend telemetry during delivery if there's a history of arrhythmia. So if we're seeing high-grade arrhythmia on Holter monitoring or very frequent ventricular ectopy, then I will recommend that you be monitored during your labor and delivery. And again, in this case, cord blood testing can be helpful, but clinical screening of that neonate, so doing an electrocardiogram or an echocardiogram or serial monitoring during babyhood and very young childhood is not practical, as this disease typically manifests later in childhood at the earliest. And so again, I will make the referral to my pediatric colleagues to look after a young child with a family history of arrhythmogenic right ventricular cardiomyopathy, but this isn't something I'm typically holding a neonate back for electrocardiogram screening, et cetera, unless, of course, they have any manifestations of heart failure picked up by the neonatologist or family doctor or pediatrician at the time of delivery. But in general, it's not something that I institute in our delivery plan in ARVC. So hypertrophic cardiomyopathy in pregnancy. So this is a very common genetic cardiomyopathy, particularly in North America. It's one of the more frequent ones that we're seeing. Again, the good news is that most pregnancies are uneventful and maternal mortality is low. the most common events that we see are heart failure and arrhythmias that typically come up in late pregnancy or postpartum. Women who are symptomatic, so if you're going into a pregnancy with pre-existing shortness of breath with exertion, arrhythmias, chest discomfort, those women may see worsening of symptoms in about a third of the time. And again, it's more likely women who have higher risk features or symptoms prior to getting pregnant. Women with significant outflow tract obstruction are going to be at higher risk for complications. And the most common complication observed is actually preterm delivery, seen in about a quarter of women with hypertrophic cardiomyopathy. However, in most cases without heart failure or severe obstruction or arrhythmia, unassisted vaginal delivery is recommended in most cases, both for the safety of mom and the newborn. Beta blockers are used in women with outflow tract obstruction, particularly if it's symptomatic, or if there is significant thickening of the wall of the left ventricle to prevent heart failure. Beta blockers are also used to control arrhythmia. So if there's frequent atrial arrhythmias like atrial fibrillation or extra beats from the bottom chamber, then beta blockers can be used to prevent worsening of that arrhythmia and to prevent worsening ventricular arrhythmia, which can lead to sudden death. Calcium channel blockers can be used as a second line agent if beta blockers can't be used. However, the mortality benefit with calcium channel blockade is not as strong as with beta blockers. Atrial fibrillation in this population is not well tolerated, and cardioversion may be considered early on if you develop atrial fibrillation during your pregnancy. And hypertrophic cardiomyopathy is one of the higher risk subtypes of cardiomyopathy for blood clots in atrial fibrillation. So it's one of the conditions where we recommend blood thinners throughout pregnancy if atrial fibrillation develops. So women who are low risk, so those women without significant obstruction or without severe thickening of the left ventricle wall or symptoms, there is no concern about having a spontaneous labor and vaginal delivery at a local hospital without cardiac telemetry. Women who are higher risk, so those women with established arrhythmias, heart failure, severe hypertrophy, or outflow tract obstruction, a planned delivery may be recommended. And a planned delivery, by that I mean a planned induction, so that the cardiac team, the anesthetic team, the obstetric team can all be present for that labor and delivery, or a planned cesarean section may be recommended if that's the only way to secure a planned delivery for a high-risk woman with hypertrophic cardiomyopathy. In terms of anesthesia during labor and delivery, the severity of the outflow tract obstruction is going to determine how safe epidural anesthesia is going to be. And oxytocin also can be used, but again, with a slow infusion rate to prevent low blood pressure, which can make the outflow tract obstruction worse in this type of cardiomyopathy. So I'll talk now about CPVT in pregnancy. This is one of the more rare inherited arrhythmia conditions, but we do see it. And obviously there are moms walking around with CPVT, and surprisingly, many of them aren't aware of it. We're picking up more and more of this disease in young people. And I'm finding that when I'm seeing young adults and teenagers with CPVT, that it's a first diagnosis in the family, and mom has gone unrecognized with this condition. So I think that that's a reassuring message to begin with. Now, CPVT is such a rare condition that case reports, really there's only case reports in the literature to look at this condition. And the messaging here is that it's critical to continue with beta blocker throughout pregnancy and labor and delivery. There have been no reported events while compliant with beta blockers. We still recommend exercise restriction, as this is an important trigger for arrhythmia in this condition. I will titrate beta blocker each trimester, either to their Holter monitor heart rate response or to treadmill stress testing in high-risk women. The optimal management of labor and delivery is unclear. There have been case reports of safe cesarean section, and there have been case reports of safe vaginal delivery. The aim overall is to reduce circulating catecholamines. And so we've had many women with CPVT through our program who are adequately managed with beta blocker, or in some cases with flecainide and a beta blocker. And we recommend cardiac telemetry, but they've had no issues with spontaneous vaginal delivery in our center. And so again, this I think is very reassuring and encouraging for women with this condition to know that in many cases, you can have a safe and uneventful pregnancy. So in review, it's really important in these conditions to have a good consultation with obstetrics to review the labor and delivery plan, to continue prophylactic medical therapy that has been initiated, to review medications which will require caution during labor and delivery, particularly long QT syndrome and Brugada syndrome, where there are very specific medications that should be avoided. We discussed the need for arrhythmia monitoring and telemetry during labor and delivery, and that very small proportion of women who will require that type of intensive rhythm monitoring during their delivery. We have discussions around cord blood testing, so whether there's a pathogenic gene variant that can be screened for in that newborn, and as well the mode of delivery. So whether unassisted vaginal delivery is going to be safe for that patient, which is the case in most women, and whether an assisted delivery or planned delivery, either induction or cesarean section, is going to be needed in very rare cases. So in terms of family planning, again, this kind of follows the previous speaker, but this is something that we discuss at a young age after they transition to adult care. So it's something we talk about, when family planning may become an issue. The biggest thing that I do in my clinic is reassurance and education. So the vast majority of these conditions, we can monitor women safely through pregnancy and labor and delivery, and we've had many successful pregnancies through the program so far. We discuss disease-specific risks and concerns, especially with some of the cardiomyopathies and long QT subtypes, which are higher risk, particularly after delivery. We have a genetic counselor available in our clinics to answer questions, particularly about education, about the transmission of genetic traits and cord blood testing. Preparation for pregnancy is a very important one, and so we review the medications that they're taking, what medications are safe in pregnancy and for lactation, and whether we need to transition them to different medications when they start family planning. We discuss genetic testing. Again, as teenagers, they may not be that interested in genetic testing, but when they're starting to have a family, it becomes something that's a little bit more forefront in their mind. And so that's something that we have close conversations about, and device surveillance when applicable. And so we start looking at whether their leads are stable and whether their battery is going to last through a pregnancy, and start looking at whether any intervention needs to be undertaken prior to a pregnancy to optimize their device therapy. So I hope that I haven't gone over time here, but at this point, I'm more than happy to answer any questions. I'm going to stop sharing because I can't see the questions, if there are any in the side here.
Thank you, Dana. We appreciate it very much. We have a few questions that have been submitted in advance, but here's one that's in the chat right now. Okay, is it okay to take Nadolol while trying to conceive, because I'm long QT type 1 and taking beta blockers since I was 7. I'm 36 years old and I'm really scared. Thanks.
Okay, no, that's an excellent question. And just last year, so we use Nadolol in high-risk long QT syndrome, and I use Nadolol almost exclusively in my long QT patients. So Nadolol or propranolol are the non-selective beta blockers that are the safest in long QT syndrome. And the good news is that Nadolol does not appear to have any significant downside in pregnancy. And so there was a recent review in Heart Rhythm where they had a large cohort of women taking Nadolol. And so just to give some background to everyone watching, there is a concern about intrauterine growth restriction with beta blockers, particularly with atenolol, which we never use in pregnancy. But Nadolol has shown to be the safest beta blocker for arrhythmia prophylaxis, and it's also completely safe in pregnancy. And so there does not appear to be an increase compared to other beta blockers on intrauterine growth restriction. The only issue with Nadolol, and again, I do continue this always in my highest risk women, is that Nadolol at very high doses is excreted in the breast milk. So this is more important for postpartum and lactation. Nadolol is renally excreted, so it's excreted by the kidneys. Newborns, and especially premature newborns, don't have the same kidney function as an older child or older baby does. And so women taking very high doses of Nadolol, I will have a discussion about screening that baby and getting the pediatricians involved in monitoring heart rate and glucose in that newborn. But at the standard doses that women are using, between 40 and 80 milligrams of Nadolol, I have no concerns with with pregnancy, absolutely, and with breastfeeding postpartum. But again, if you have a newborn, a premature newborn, or very, very tiny newborn, or you're on very high doses of Nadolol, so if you're taking 160 milligrams of Nadolol or more a day, then more of that is going to get into the breast milk. And I don't recommend stopping it, absolutely, but I do recommend having more of a discussion with pediatrics during breastfeeding about whether that baby's having too much beta blockade. But no, continue your Nadolol, absolutely, and don't be scared.
Okay, thank you, Dr. Spears. Another question that was asked previously, this person has an ICD, and the question is, if I received a shock during pregnancy, will it harm my baby?
Absolutely not. So no, there's no evidence that cardioversion or a shock through the defibrillator or cardioversion externally. So when we have to cardiovert women with atrial fibrillation or ventricular arrhythmias, there's no concern about that harming the baby. In the defibrillator, it's a closed loop. And so the fetus is not experiencing any of that shock vector that you're receiving. And so absolutely not. The concern, though, is whether you're having unstable arrhythmia that may need to be managed a bit more closely, and whether you're a higher risk arrhythmia substrate that needs to be followed a bit more closely to protect the baby through the pregnancy. But an ICD therapy, no, I would have no concerns about that at all.
Right, thank you. Our last question here. I'm pregnant, just diagnosed with long QT syndrome. My doctor is concerned about starting beta blockers because of my low heart rate and blood pressure. Is there a way that I can still safely take beta blockers?
Absolutely. And so this is a common this is a common pushback that we get with first of all, with heart rates. Many women with long QT syndrome have baseline bradycardia. And so depending on how low your heart rate is, you may require some pacing support to keep your heart rate up, because some of the arrhythmias in long QT syndrome are mediated by having a very low heart rate. And so that's something that an expert in inherited arrhythmia conditions would be able to guide decision-making around whether you need pacing support. But if this low heart rate is not pathological, a heart rate of 30, for example, I would be very concerned about and might talk about pacing. But if the heart rate's 50 or 60, then we can usually initiate beta blockade without dropping that heart rate too much. In terms of blood pressure, women, and especially in pregnancy, the blood pressure tends to be much lower. I do recommend adequate salt intake and hydration, especially during pregnancy when your blood pressure is going to fall a little bit naturally. And so supplementing, volume loading can help you tolerate a beta blocker better without a lower blood pressure. And it's important to know that beta blockers are terrible antihypertensive. So we don't use them to treat blood pressure problems because they don't lower the blood pressure that much. So in yourself being, a young female who's pregnant, definitely make sure that you're having salty snacks, nuts, soups, things like that to keep your blood pressure and volume up. But I have no concerns about taking a beta blocker unless you're in that very, very low heart rate, in which case that's a more complicated issue where you may need pacing support, both to protect you from arrhythmias and also to allow for beta blockade.
All right. Thank you, Dr. Spears. One final question from Ruth. Any news about pregnancy with DSP cardiomyopathy?
Yeah, so DSP cardiomyopathy is classified with the arrhythmogenic right ventricular cardiomyopathies, even though in this particular subtype of ARVC, it's actually the left ventricle that may be preferentially involved. And so here, again, the same recommendations regarding your heart function and your arrhythmia burden are really important. So if you have preserved left ventricular function and controlled arrhythmia on beta blocker or no arrhythmia at all, I have no concerns about proceeding with pregnancy. And the same guidelines apply. So rhythm monitoring and heart function monitoring during pregnancy, but there's no indication that a desmoplakin gene variant is going to give you a higher risk than the rest of the ARVC population in terms of pregnancy and labor and delivery.
All right. Thank you very much. We appreciate your time today, especially on a vacation day and taking time away from your family. So thank you so much.
You're very welcome.
Bye-bye. All right. And our final session is Ask the Experts, our Q&A session, interactive with 3 experts. We have Dr. Michael Ackerman, a genetic cardiologist from the Mayo Clinic in Rochester, Minnesota. We have Dr. Sanatani again from BC Children's Hospital in Vancouver in Canada, and Dr. Hari Tandri, who's an electrophysiologist and ARVC specialist from Vanderbilt University Medical Center. So if you have questions here, you can put them in the chat, or if you want to ask your question verbally, you can just mark the raise your hand button and we'll call on you. And gentlemen, we have some questions that we have compiled from earlier. I know that I think some of you are on a mobile device, and I'm not sure if we can see you at the moment, but that's all right. We can at least hear you.
Marcia, are you able to see me?
Oh, there I see you, Mike. Thanks.
Yeah.
Yes, great.
Well, before we get started with the question and answers, I just want to say hello to everybody. And as we've come past 4 hours, it looks like we're at 4 hours and 20 minutes of today's program. And I hope everyone's enjoyed it. On behalf of the SADS Foundation, thanks to all the speakers, starting with Dr. Andrew Landstrom as the first, and 4 hours later, Dr. Spears. And so here we are, just the cleanup act, the final round for those missing questions or questions that you want us to address again or perhaps differently in terms of our answers. And so grateful to have Dr. Sanatani and Dr. Tandri join me. And we will do this rapid fire. I know it's been a long day for everybody, so I promise you we will be done at the top of the hour. So we will not press on, since we're about 20 minutes late in the program for everybody. So let's get started, and Dr. Sanatani and Dr. Tandri and I will try to do our best with quick, precise answers to your final questions.
All right. Thank you, Mike. So one that has just come in from Kristen. My son has depression and anxiety and is getting tested for ADHD next week. What are the safest medications for treating ADHD, depression, and anxiety?
That's a great one. Shu, do you want to start with that, or do you want me to tackle that?
I'll jump in and I'll let you correct me. We see a lot of this in pediatric cardiology and pediatric heart rhythm. And first of all, to the person making the inquiry, thanks for sharing, because I know these are common concerns in our population, and people aren't always comfortable to talk about things like that, especially mood disorders or any challenges with learning. So the overwhelming message is that just about everything is safe. And our wonderful moderator Mike Ackerman has done literature on the safety of stimulants in long QT, and so there's really no concern with any of the medication categories. It's always good to make sure, though, that your long QT specialist is aware, and if you're in the midst of medication changes in that sphere, or you're undertreated, or your diagnosis is of a different condition, just double check that they truly are okay with it. And most stimulants, as I say, and most treatments for ADHD are totally fine. The actual amount of QT prolongation with any of the antidepressants is very low. But where I do get a bit nervous about the whole www.crediblemeds.org and the whole risk with drugs and long QT is when you start having multiple medications and maybe other things that may be affecting your risk. So if your nutrition is not optimal, if you have other medications that the pharmacist doesn't know about, or someone prescribes you an antibiotic while you're already on 2 potential QT prolonging meds. So it's just caution, but definitely a good psychiatrist is going to be familiar with your long QT. Venlafaxine, I always struggle to say that. That's one of the ones that we know that's quite safe, but there's a whole host of them. And even some of the ones on the, be careful about are actually safe. They produce a very minor increase in your QT. So the most important thing is to get the right treatment for your depression.
I think that's great, Shu. I don't even think we'll need to add anything to that. I guess rather than them having asked you and me what we think is the best stimulant, the best antidepressant, I think we always like to say to their therapist, we need you to pick the best treatment that you perceive for the situation at hand, whether it's depression, anxiety, and not be trying to pick the QT friendliest one, even though you might feel that it's not as good of an antidepressant. Pick the best. Let's treat it the best. Let's let us worry about the QT side of the equation, because almost always there's very, very little to worry about. And I think, don't you agree, Shu? This is an area that we've got to do a lot better on than we're doing. We're leaving way too many long QT, CPVT, Brugada patients with inadequately treated anxiety and depression for a variety of reasons out of QT fear or heart fear, that we just have to do a better job than what the community of providers have done so far.
Absolutely. And the beta blockers often get a bad rap. I know that, certainly they have a lot of side effects and they're, they are life altering for many people, but sometimes the depression is not just because you're on a beta blocker that you've been on for 5 years. So it's really good to, work with a, good professional that's going to be comfortable and not just say, get outdoors more and your depression will go away.
Great. And so, Marcia, do you want to tackle these, or do you want me? I've got the chat screen open.
We have a few that have come in earlier, so let me
Okay.
just start with those. I'll read them for you.
Yeah, you go
all
for
right.
it.
From a family member, I was wondering if you have any information on the safety of bariatric surgery for long QT patients. On top of the operation, are there implications for afterwards with dehydration, et cetera?
Yeah, great question. The experience is very, very minimal, at least at Mayo Clinic. I've had a couple patients go through bariatric surgery. In general, no matter what the genetic heart condition is, I would say my premise is, if their management of their obesity is needing bariatric surgery, we need to press on and get them through bariatric surgery, because a life of obesity carries with it health implications that are far, far greater than their long QT or their CPVT or their whatever. And so I don't fear very much about bariatric surgery at all. Making sure we're electrolyte balanced, looking out for swings in electrolytes. But my worry meter about a patient considering bariatric surgery is almost zero. Shu, you and then Dr. Tandre, do you have any concerns for the ARVC patients?
No, I think again, this is a very important treatment that's reserved for relatively rare but severe conditions, and so our job to get them through the procedure safely. If it means that they do it on a day where the electrophysiologist or the genetic cardiologist is available in case things are interesting in the OR, then do it that way.
And I'm not sure if Dr. Tandre made it on. He
Okay.
may have had some connection issues, not sure.
All right. Well, I have no concerns for the ARVC patient either. And also it's awfully early, but the new weight loss drugs where they are getting FDA approved indications for the purpose of obesity and weight loss, there to date is zero QT signal of concern or cardiac signal. So again, and some new options now besides bariatric surgery to help individuals struggling with obesity.
Okay, thank you. So April asks, my 21-year-old son has long QT type 1. His EKGs are relatively normal and has never had an event. However, long QT1 is all over his medical chart. Is this going to prevent him from entering the military?
Yeah, I'll speak to the United States and then have Shu speak to what might be unique for Canada and military service. Unfortunately, yes. In the United States, we would work very, very hard if somebody is passionate to serve in the military, and thank him, your son, in advance for having that desire to serve. And we do have some success stories of getting in. If you're already in the military and then you're found out to have a cardiac condition, but they've trained you to be an elite Green Beret, a lot easier to keep you in the military. But on the recruitment front end, it is difficult, although I think the needle is gradually shifting, just like it's shifted for elite athletes. But right now, at least in the United States, there are many, many men and women who want to serve, and that allows the military to pick those who have basically unblemished medical health records. And there's a general guide in the United States of being so-called worldwide deployable, WWD, that conditions like long QT make it a little bit difficult to achieve. But I would not give up if that's your son's passion. We've written letters to senators for the state in which they're trying to serve and so forth. So I would not give up immediately, but it is hard with that on their record in the USA. Shu, what about up in Canada?
Yeah, similar. I'm not that familiar with the specifics, but in general, with any of these large administrative organizations, it's not that different from, getting your pilot's license or, the military or other vocations where you're easily flagged. And I mean, the first comment, and I might have missed this, but Mike's done, I don't know what the number is. He's probably in the thousands now, where you always have to make sure that the diagnosis is correct. So if you can get rid of the diagnosis, then, that's obviously a way to go. If you do have that in your file, though, it is going to stick with you. And, with some advocacy from your genetic heart clinic, some letter writing and that, but people don't always necessarily listen to the reasoning. Like a genotype positive person, so someone who has a genetic risk but has no evidence of the disease, is essentially almost the same, is almost the same as a person who doesn't have the disease. And so, but science and logic don't always work together. So.
All right, thank you very much. So Corcia asks, I have 3 questions. Can the QTc values of long QT babies continue to rise? And until when is the QT interval reduced by propranolol? And how effective are beta blockers in high-risk patients with QTCs greater than 500?
Shu, go ahead and you take a swing at these 3, and I'll do cleanup.
Sure. Great questions. And, I feel like I'm providing some background excuses for everybody. And I'm going to continue to do that because I'm a bit of a hard nose on these things. And first of all, I don't believe most of the QT intervals that come across my desk, especially the ones that are just printed out on the computer, and especially in newborns where the heart rates are very high, and the math formulas that we use really don't serve babies very well. And so I'm always a little bit cautious about believing the numbers, and I like to look at the ECGs myself and measure them. And that's sort of the starting point. It's in part it's the number, in part it's just what the QT looks like. Are there other factors? Is this a worrisome form of long QT? So the number generally stays fairly after those first few weeks of life. The number does tend to stabilize, and there are some fluctuations in the first year, but really you don't typically go from a 480 to a 600, and you don't typically go from a 500 all the way to a 420. But again, this is based on people that really know what they're doing, looking at your ECGs. Because of the math that we use, a slower heart rate gives you a shorter QT interval. So it's not necessarily that the beta blocker is shortening what's happening in your heart cells. It's just that the numbers start looking very different. And so we'll often have to exercise someone off medication if they're one of these borderline cases. And then I think the last question was, just the effectiveness of beta blockers. I mean, beta blockers in type 1 long QT, which is one of the two most common, are excellent. It's hard to beat. But even in long QT type 2, they're pretty good, but it's a big drop off. So I would say in type 1, they are, I don't know that there's that much better that we're going to do. Type 2 and other types, definitely beta blockers are as good as we have, but people are working on better.
Yeah, I'm interested, Shu, whether you've observed this too, but I've been impressed that the first ECG of almost any of our patients that we obtain is almost always the longest QTC we catch. And especially if that first ECG is the newborn ECG. And then there's a lot of newborn transition improvement, but I'm always impressed that even the non-infant, the teenage got their screening, the college kid got his screening ECG. That first QTC, that first ECG seems to, for whatever reason, register their longest resting QTC. And whether it's the first ECG, so it's an unfamiliar environment, they're a little bit anxious, they're a little bit jazzed, whatever. And then you see QT regression and improvement. And I think the point behind that observation is never, ever risk stratify based upon the patient's first ECG or their worst QTC that you've captured, because that may not be reflecting who they are the majority of their time. Have you kind of gathered that also?
Yeah, no, absolutely. And I think every time we talk about this, I give a little shout out to your Van Dorn paper. Van Dorn is the last name of the first author. A wonderful paper about the timing of the ECG. So the kid comes into the emergency department with a fainting episode, gets the ECG, but even a few weeks later, it's gone from an abnormal to a normal. So, those hormones, the stress, the autonomic nervous system, all of that factors in. So, yeah, I completely agree.
The other thing that the propranolol part is for the questioner is if the patient is LQT2 or LQT3, there could be some true QT improvement happening, because propranolol, unlike the other beta blockers of nadolol, propranolol also has some weak mixilotine-like properties. And so that's one of the advantages of propranolol and why some people advocate propranolol above or instead of nadolol for LQT3. And so I like propranolol. I like nadolol a lot. I like both of those.
Okay, thank you. Amy asks, who is affected with CPVT, how often should you have your flecainide levels checked?
I think it depends. So I'll start with that with Shu thinking about that. But I think if we have a very stable CPVT patient or ARVC patient that we're on flecainide, and we're already very pleased with their stress test, then flecainide for me is I do it once a year when I see the patient for their annual visit. On the other hand, if it's a new patient and Shu and I are trying for what I would say is the new goal in CPVT, which is to cure the stress test, to make the patient's stress test on therapy look like Shu's and my stress test would look like. Shu's would look better than mine, though, better performance, of course. But there, I might be getting a flecainide trough level monthly and a monthly stress test, especially if we're starting with an ugly looking stress test and we're gradually getting it to look better. And the trough level shows that we have more room to nudge up the flecainide. So I would say early in the game, while we're curing the stress test, much more frequent flecainide trough levels. On cruise control, once a year, twice a year at most.
Yeah, and I'm completely delinquent. I would say that in general, I use very low doses because I found, quite good therapeutic effect at what is well within, safe dosing ranges. So definitely a level if they skew from what's expected. And, the challenge, of course, with especially the adolescent patients is are they taking it like they say they are? And so is your level going to be reflective of what their real life is? Or have they actually just started kind of like cramming for a test? They know they're coming in to see you, and suddenly they've taken, a week's worth of pills in 2 days. So, but yeah, we haven't had to rely on it much, but if you deviate from what we expect is going on, then absolutely.
And I think you made a neat point there, Shu, and I've observed it too. It looks like for CPVT and to get that very satisfying stress test, the flecainide level doesn't need to be very high. I'm off our therapeutic range here at Mayo is 0.2 to 1 on our trough on our level. And it seems like I get a really nice satisfying stress test with their levels in the 0.4, 0.5, 0.6 range, that we're not needing to push the levels very high. Have you been struck with that?
Yeah, probably don't have enough data to speak intelligently, and I think you and I are, of course, in different units, of course, but no, absolutely.
Good questions.
All right, here's another one. A female, 37 years old, has long QT type 1. She says her cardiologist says that beta blockers become less efficient with age and must have an ICD. She's been taking beta blockers since she was 7.
Well, a lot of problems. Great question. A lot of problems with that, including that cardiologist is completely wrong. So there's no evidence of Nadolol or propranolol losing its therapeutic efficacy with age. Zero. Unless Shu's going to tell me something that he just read something. But Shu, is there any basis for that? That feels like fake news to me.
My first reaction was much less professional than yours. Mine was just time for a new cardiologist.
That was going to be my follow-up.
Yeah, I don't have any long QT type 1 patients who have ICDs.
And you certainly don't start there. And that's where, unfortunately, in America, I unfortunately see a lot of patients already with the ICD in place for LQT1 and LQT1 Shu that you would say, what? This is low risk LQT1 for which we might actually be tempted to do non-therapy. And they already own a defibrillator.
Okay, thank you. Amy indicates she knows there's research for medications to be specifically used for CPVT. What are the updates on that research?
I can speak to a little bit of a project that I'm involved with to the extent that I'm allowed to speak about it. There are certainly some companies that are interested in different approaches to CPVT, and CPVT is interesting because the molecule that I was speaking a bit about earlier today, if you happen to be there, the ryanodine receptor, it interacts with so many different important proteins. There are definitely some interesting targets, and I know that there are a few companies going at different areas of these proteins. Certainly the specific company I'm involved with, where we have not started testing the molecule in patients, in real live patients in the clinic yet, but that is coming.
Yeah, and I think so. That's the Cardurian study.
Yes.
Yeah. So the other one for the families out there is the Armgo Pharma study, which I'm one of the principal investigators along with Arthur Wilda. And I believe, I don't know if I'm right, but I think the first CPVT patient got treated with the Armgo Pharma drug within the last 2 weeks in Amsterdam. We'll be enrolling our first, we're all up and running for enrollment in the United States and should be enrolling patients with CPVT by end of summer. But as you know, it'll be interesting for both trials in enrollment, because for the families out there, we don't remove your current therapy. And if Shu and I have done our job well, then they're not going to be having enough ectopy to enable them to be eligible to be enrolled in the new drug, the new kid on the block. So I'll be interested, as I'm sure you will be, on how we do with enrollment are there enough CPVT patients out there with a enrollable stress test, because we haven't done, or there's too much persistent ectopy on their current treatment program. But it's exciting to think that there's 2 new molecules that have very interesting and at least in the dish and in the model systems, exciting potential to be a really good treatment. And who knows, wouldn't it be wonderful if we eventually don't need beta blocker anymore, because beta blockers work great, but as we published, many patients don't view their quality of life as satisfying as it could be because of the so-called beta blocker zombie side effect, just feeling sluggish and tired of feeling sluggish and tired. Now, those who don't have the beta blocker side effect, it won't start tomorrow just because we said it. So many people, the beta blockers agrees with you just fine, but for the 1/3 of you where the beta blockers don't seem to agree with you, that's why Shu and I are motivated to be part of these trials, to find new therapies, better therapies, eventually replace our current treatment strategies with new strategies altogether.
And I love that paradox that you've pointed out. And I think, I don't know how many people in our audience really understand that, but the companies or the people with some money and the companies, they come to the people that are sort of known in the fields or have a bit of a research program, whose patients usually are on the treatments they're supposed to be on. And really they need to be going out into the periphery and finding the patients that aren't on what I call optimal treatments. But anyhow, that's a different conference.
Yeah.
It looks like Dr. Tandri has joined.
He has just joined us, yes. And so we have a few questions that are ARVC related that we'll include. So
yeah, he's got to take the next 5 at least.
okay. So Nadine indicates, Dr. Tandri, is there any new information on the DSG2 AC patients with pain episodes? My teen is still on Celebrex, Carbapenem, and Tylenol to help manage the pain episodes, in addition to antidepressants for anxiety, depression, and PTSD. So welcome.
Thank you. Apologies for joining late. Had some last minute issues that I had to deal with.
No worries.
No, thanks a lot. Good to see you, Krishna.
Oh, thank you. So I think chest pain seems to be a little bit more common in the DSP and DSG cohort in our series. I think there's a bit of more presentations of myocarditis. And the association with elevated troponins is not always clear. Sometimes patients present with chest pain, not really having a clear troponin rise, but sometimes it's clearly associated myopericarditis along with it. I don't think there is any specific combination of therapy that works really well. We have tried steroids, we have tried colchicine in these patients, and it's not like one size fits all. There are patients who do take nonsteroidals, and that seems to do it, but it has a remitting and relapsing course. So although they have these episodes, there's a period of quiescence where you don't have any chest pain at all, and it happens. One thing is becoming clear that these episodes don't seem to mean that the disease is getting worse. That's one thing that I want to reassure people, that just because you're having repeated bouts of chest pain, that does not mean that there is ongoing muscle damage or there's actually ongoing worsening of cardiac function or so on. Doesn't seem to be a good correlation between that. And it's not always that not all patients with DSG again have these chest pain, and not always with DSP have this chest pain. So I think the different treatments that are available are clearly these non-steroidals. We have used colchicine with some benefit. And of course, steroids seem to help in the acute phase of the illness, both in terms of this anti-inflammatory effect and probably reducing also the chest pain.
Krishna, I'm curious your thoughts. Do you think part of the issue could be our messaging? Meaning, we teach our ARVC patients new arrhythmias, new palpitations, new chest pain to alert us. And I wonder if because you can picture that if they're having a true myocyte flare, that could give true cardiac chest pain. But the vast majority of the time, their chest pain has nothing to do with their disease process. And I wonder if we have contributed to it, just like in a way, it strikes me as quite intriguing that with left cardiac sympathetic denervation, when we used to never mention post-denervation neuropathic pain, it never happened. And now that we have seen 10 years ago when we started seeing cases, we felt like, well, in the name of full disclosure, we ought to inform this as a possible side effect. And then invariably, the right demographic, 20-year-old to 40-year-old females who had prior fibromyalgias or pain sensitization issues, almost a 100% post-denervation nerve pain response after their surgery. And I think words are powerful, and I kind of wonder if you've seen this or sensed that, or do you think there's something unique about DSG2 and so forth that's giving true genotype-mediated pain phenomenon?
I don't think there's anything genotype mediated. I think chest pain happens to certain, percent of patients with desmosomal myopathies in general. And it is one of the things that in the slew of different cardiac symptoms, chest pain is also mentioned with some periodicity in ARVC. I'm not sold that this is something specific to the mutation. Although presentation with myocarditis has been more recognized in the DSG and desmoplakin sort of cardiomyopathy. So myocarditis does not really always mean that chest pain. So it's just that when during evaluation, they find the elevated troponins and so on. So I agree with you. If you look for it, you'll find it. Let me put it this way. In most of the time, it's almost like a self-fulfilling prophecy. If you give somebody a drug and tell them that these are the side effects you're going to have, you will look for it. You can find those side effects. But there is definitely some truth to patients having repeated bouts of chest discomfort, especially, I've seen more in teenage women for that matter. They have repeated bouts of chest pain, which are sometimes incapacitating and do require some thought into how we deal with that.
Okay, thank you all. So let's see. Can an ablation be performed on 400 milligrams amiodarone and 600 mexiletine and 5 milligrams of bisoprolol? Even with this therapy, this person's in instant trigeminy, and when he stands up, he or she, they have an ablation soon, it says. No structure heart damage, preserved EF, no MRI, ARVD findings, but severely aggro arrhythmias.
Yeah, I can take that question. Yeah, so it clearly looks like all these drugs are being ineffective in suppressing the arrhythmia for the start, right? So I don't think they will interfere with the ablation procedure itself. In some ways, it's always nicer to have patients be on some sort of antiarrhythmics and still have arrhythmias. So it gives you a good justification saying that, medical therapy hasn't really worked, and you actually, go and perform the ablation, it'll be successful. I don't think there's going to be any problem doing that. And after the ablation, of course, once it's successful, you can safely come off all the medication.
Okay, thank you. Let's see, Nadine asks, the mitocyte flares my teen has had at the ER with morphine. I was hoping there was something that was more clear and that EPs don't always work with the pain teams to help figure that out.
There's a big disconnect between, what we do and many other subspecialties. I would say even as close as heart failure. So I agree with you that, we always need to reach out and work with people who don't quite understand where we're coming from. This is new for the pain service, to be able to understand that there is a myopathy, which is desmosomal and that causes pain, and we need to address this and so on. There is a gap in working out and reaching across the aisle and trying to work with other teams. The place where we saw a big gap was pain management usually does sympathetic blockade. They do stellar ganglion blockade and so on. It took a bit of a organizational structure to actually even go ahead and do that, to be able to do that for refractory arrhythmia. So yes, there is a big gap, and thank you for pointing that out. We do realize that, and we need to fix that as we move along.
I'll just make a comment also just on the pain side. The literature in the last few years has been really exciting as the ability to image sections of the brain has improved, and really getting some studies, especially with functional MRI, and seeing how some of these pain circuits work. And we've started a little group called the Brain Heart Group, just because there are clearly some overlaps, and we some of us are familiar with this, stress, cardiomyopathy, and things. So I think in the next 5-10 years, the connections between the heart and the brain are going to become a lot more clear to us, and maybe get at some of those questions. Why did that person have that cardiac event on that day that happened to be a very stressful day? So more to come in that space for sure.
Mm-hmm.
Okay, thank you. So Carrie asks, what are the specific exercise recommendations for ARVC? She used to run half marathons and ultra marathons, and now has been instructed not to run. Her aerobic endurance was developed, and she's maintaining her heart rate under 140 beats per minute as a 30-year-old female. And that's at around 9 miles for easy runs. The guidelines for ARVC in 2019, was wondering if there's any update on those 2019 guidelines on this topic.
Dr. Tandri, why don't you tackle that to start with, and I'll give a perspective as to where I think ARVC and exercise is going to be heading in the future.
Sure. So I think for a long time, our general recommendation has been try to avoid endurance sports as much as possible. And that message really meant different things to different people based on where you start. If you're running marathons, being, not doing anything is a massive steep drop from where you were to someone who's casually exercising and whatever, easy to change their lifestyle and so on. And again, I have come to realize that mental health is critically important, and really has a very high bearing on both the disease progression and also has a big bearing on the quality of life, of course. And so there is, it's clear that the more you do, the more you train your heart, meaning the more you condition your heart, there is some evidence right now that actually suggests that remodeling is the problem in ARVC, that the more you challenge your heart, there is basically myocyte destruction and replacement fibrosis, and worsening is the basically ventricular function worsens as time goes along. That being said, we have come up with ways to say that, you limit your heart rate, you basically pick a limited amount of exercise that you want to do, and we closely monitor both in terms of doing repeated Holters and echocardiograms, and monitor the your cardiac function and including arrhythmias and so on, and kind of figure out what works for you and stick with that. So it's not like one size fits all. Again, you really work with every single person to try and figure out what keeps their sanity and what's not going to worsen their ventricular function in the long run. I think gone are the days where you strictly draw a line and say, you don't do anything and basically sit tight. And it's clear there's not much evidence supporting that strategy either, because it really leads to other problems in terms of, worsening metabolic syndrome and so on. So I think some exercise is okay, and try not to improve on yourself. Don't do a mile today, 2 miles tomorrow, 3 miles the day after, and try to, improve your exercise capacity as time goes on. And that is the problem with ARVC. Your heart's not able to give that extra every single time. And the more you challenge it, the more it's going to react in terms of developing fibrosis.
Yeah, I think for the ARVC community, I guess I see hope and optimism on the horizon, just like 23 years ago in long QT, the law of the land was no sports for you, nothing. For HCM, nothing. For Brugada, and it's changed and changed quite dramatically in 23 years. And I think ARVC probably is the final genetic heart disease within the SADS family where we've been slowest to try to embrace some sort of heart healthy level of exercise and activity. And I think we're going to be learning a lot. I think for the athlete, where their training program in a way brought out their ARVC with or without a genetic driver. And so somebody like Dr. Tandri can easily make the diagnosis. Well, then continuing in that said activity probably isn't going to happen. But for many, many other ARVC patients who are caught by cascade testing, and then they're told to shut down their engine at age 10, I think we've made a colossal mistake in that area. In fact, so much so, as Shu knows, it's led some families who are very, very, very bright to say, why would I get cascade tested for my ARVC variant? Because it's going to cause me to be disqualified. I'm going to stay active. I'll stay seeing the doctors, doing my annual test, but until and unless the standard test, ECG, echo, whatever, show that I have ARVC, I'm not going to get the genetic test. And I think that is equally a misfire, because I want to know who's variant positive so I can follow you. And I don't want you to have the fear that by getting tested means we're going to shut you down from everything you love. And so we have lots of opportunities in this area, but I see an exciting day where we will get smarter about penetrance. And for the person who we learn owns the variant, but is never going to show it, no matter how many marathons they run, maybe we will get to be very lenient with our prescription of exercise. Whereas those where we see they have features of fragility, vulnerability, remodeling, we may say, you know what, marathons are not for you, but let's find a sport that would work for you, that gives you that mental health satisfaction, that competitive edge, and so forth. But I see the lack of genetic testing in ARVC families for the children for specifically that reason to be a big problem in the US. And Shu, I'm wondering if that's a similar observation that you have in Canada, where the families are saying, I don't want to get variant tested because you're just going to kick my child out of everything they love to do if they're positive.
Yeah, no, definitely. We could have spent the whole hour just on exercise and ARVC, and I think adult ARVC is a very different condition from the 9 or 10-year-old that presents with a blown out right atrium and right ventricle, and I have such a case right now, and he has far more advanced disease at his young age than most adults ever get to. So I think, there's ARVC that is very malignant and dangerous and rapidly progressive, in which case I don't think your exercise tolerance your exercise avoidance is going to do anything to help you. And then there's probably people that are able to advance their phenotype or make their ARVC present. But I think, I feel like we don't have a good enough understanding, and ARVC is that I think it's one of the most diverse conditions that we look after. It's not one condition. It's many different types.
Okay, thank you. We have
and Marcia, just for the audience who've been amazing, probably for 5 hours, well, exactly 5 hours now, just so that everybody knows, Marcia has 10 minutes left on her counter, for us at least, before they all give the wrap up and Shu and Krishna and I disappear.
Okay. So Scott's daughter has ARVC with the PKP2 gene. She's 20 years old. His question is, how do we know if our daughter is a good candidate for genetic testing? And if she is, how does she get into the testing?
No, it's for gene therapy. It's how do I know she's a
Gene
candidate
therapy.
for the gene
Oh,
therapy?
yeah, sorry, I didn't read that right.
And the same with
Yeah.
Heather, has a son, 25, wants to know
Yeah.
about therapy.
Mhm, genetic therapy.
Sorry.
Great. An exciting time, and I'll have Dr. Tandri get update on, but we have, I would say, and I know Dr. Delmar gave a lecture on the state of gene therapy, but I've been on staff 23 years at Mayo Clinic. The first 20 years, we basically had zero conversations about new therapies for genetic heart diseases, zero. And now in the last 3 years, we have all kinds of new therapies in the pipeline. You heard about 2 new drugs for CPVT. There will be starting enrollment later this summer. A new drug for long QT syndrome looks very promising. And then in the gene therapy space, absolute explosion, with the particular starting point going to be our ARVC families, but only those ARVC families who have PKP2 mediated ARVC. And so those studies are starting. There's several drug companies leading those. Tenaya Therapeutics has a PKP2 trial getting ready. I believe Rocket, another company, has one. I'm probably leaving out 1 or 2 other gene therapies because it's getting crowded in the PKP2 space. They all want in, which is great for our families. I would just say for the 20-year-old and 25-year-old, keep watching. You'll be SADS Foundation will be posting the studies, the eligibility criteria, the ways to get connected to those study sites. But you can imagine with any gene therapy, your disease has to be really, really obvious. And all of the gene therapy studies are going to start with really obvious disease of moderate to severe severity for which you already own an internal defibrillator. I think most of these studies are going to start with an internal defibrillator requirement just out of a tremendous abundance of precaution, just in case there's a surprise and the gene therapy somehow is irritating to the heart cells in an arrhythmia producing way. So obvious, dramatic, impressive disease for which your doctor has already committed you to an internal defibrillator. Tandri, any new insights or extra insights on PKP2 gene therapy that's coming down the pipeline quite quickly?
I think you're spot on. I think the lot of discussion on who should be the first entrant patients and what their characteristics should be. And it's really centered around safety. The first round of studies will be centered around monitoring what the effect is and more focus on the safety of gene therapy itself. At this point, they're collecting almost the phase 0 information on who are the patients, what sort of stages of these different are they in currently, and to kind of define what is going to be the target group that's going to first receive gene therapy. Clearly, the patients who have no phenotype or patients who basically have very minimal phenotype without an implantable defibrillator won't be the first group of patients who will get into these trials. But again, it's something, as you said, the momentum is there, and it's not really clear how soon this is going to get into a different stages of the disease, but definitely something to watch out for within the near future.
All right, thank you all. April asks, why is long QT an automatic denial to donate blood?
Yeah, Shu, do you have any insight in that in Canada? I think this is one of the great myths out there. There's zero reason why any of our genetic heart diseases should be disqualified for blood donation. I hear this. I don't know. I didn't fact check it with our blood donor program at Mayo, but I've heard more than one patient from different parts of the country. So does anybody have any idea as to what's behind that? Because there's zero basis for it as far as I can tell.
I'd have to go and do some work on that myself. I'm not familiar with that, and I can do a bit of digging, but nothing comes to mind.
Okay, thank you. So
Yeah, the
Christine,
gene, I mean, I don't know if there's a fear, a fear, right? That somehow the gene is in that blood sample, and therefore a blood recipient will somehow then get the disease. So it has to be something crazy, because otherwise I don't get it, because there's no biological basis for a denial that I can picture, unless it's just their rules.
okay, thank you. Christine asks, are leadless pacemakers being recommended in children with sinus node dysfunction? And are they as safe as traditional pacemakers?
Shu, why don't you grab that?
Yeah, first of all, lots of red flags going off for me. There sinus node dysfunction, so where the timer of the heart doesn't work properly, is an extremely uncommon condition. Even within the SADS conditions, I know we heard Cecilia Gonzalez talk about it being part of Brugada. But even within the sodium channel families, having a sinus node that doesn't work that well enough that requires a pacemaker is pretty rare. So I definitely, I'd be asking hard questions. Now, if your sinus node doesn't work, and there are patients like that whose sinus nodes don't work, the decision about whether you need or don't need a pacemaker should definitely be based on more than just numbers. It should be based on quality of life and ability to exercise and things like that. I'm going to be a pretty late adopter of the leadless pacemakers in children. I know that some places are putting them into children, but the devices don't. First of all, in a child's heart, they're quite large compared to the actual chamber, and only one of the major brands can actually be removed, and that is probably described as more seamless than actually would happen. If you think about how your body forms scars, imagine trying to get something out of a child's heart that the heart has been hanging on to for 5 years. So I'm nervous about the enthusiasm. I feel like this is one of these things that works pretty well in maybe a 60 or a 70-year-old, that I need a lot more technology development before it's going near me.
Thanks, Shu. And just for those, if we don't get to your question, I promise we will tackle them on SADS Live, episode 122, in 13 days, or one of the next SADS Live equivalents up in Canada from Shu. So we won't miss any of them that we don't get to. I know the SADS Foundation team will keep these, but I will give Marcia the permission to pick out her 2 final questions to ask and for us to answer, and then call it our day.
Got it. All right. So from Megan, I have drug-induced long QT with symptoms after taking several medications that prolonged QT, such as I'm not going to pronounce these right, fluconazole, tachycardia, and syncope that caused that. And then mitriptyline, a QT of 599 with tachycardia and near syncope. Her genetic testing was negative. Her resting EKGs off all the medications demonstrated a normal baseline QTC. So her question is, should she be on a beta blocker? And the other part, she has identical twin 3-year-old girls, and their genetic testing is also negative and not sure if they're affected. And should she worry about giving them medications that could prolong their QT? So should she be on a beta blocker?
No. So if she has drug-induced QT prolongation that normalizes with discontinuation of the drug, and the drug prolongation is not coming out because she has underlying long QT, which she does not because her genetic test was negative, she just is a QT prolonging drug reactor. So what's critical for her is that hit list of drugs to avoid should really be avoided. She doesn't need a positive genetic test for that list of drugs to be viewed off limits. She's proven the necessity or importance of not taking such a drug. She doesn't need to be on a prophylactic beta blocker. And if her identical twins have had screening ECGs and they're normal, then they probably don't need any follow-up. Might I do a stress test around age 10 to 13 just to see, is the QT reaction during the stress test clean? As a one extra look, I might, but I would be doing it from the premise that we're almost certainly dealing in this case with isolated acquired QT prolongation, for which QT drug avoidance for her and her alone is probably the only treatment that the nuclear family will need.
All right, thank you very much. And last question. With Brugada syndrome, what are the chances of cardiomyopathy developing, and is an echo every couple years recommended? From Christine.
Christine will give you the trifecta. So we're going to let each of us tackle that. Dr. Tandri, you first, Shu second, and I'll do cleanup. And then the three of us will say goodbye.
Yeah, that's a wonderful question. The classic Brugada syndrome does not have a myopathic process behind it. It's purely an arrhythmia driven mechanism, with ventricular fibrillation being the most predominant arrhythmia. Occasionally ventricular tachycardia have been described. In general, I do not think there is a value in yearly echocardiography in Brugada to monitor ventricular function unless there are any new symptoms. There has been some reports of overlap of Brugada syndrome and other desmosomal myopathies or arrhythmic cardiomyopathies, but there are far few in between. I think in our general practice, we don't see that as a myopathic process. And we basically, if it's a classic Brugada syndrome, well diagnosed with an SCN5A mutation or whatever, I do not think that you would expect progression of valve dysfunction or anything like that over a period of time. So it would just be followed symptomatically. And yes, of course, you'll be being followed by a cardiologist, or if you actually have a device, you'll be followed by an electrophysiologist anyway.
I don't disagree. I think we're still figuring out a little bit about Brugada syndrome, and every year someone writes a paper that says, okay, we've finally figured it out. And so there's some Brugada that you can ablate. So something's abnormal in the right ventricle. There's other Brugada that's probably quite different. My own experience, which is limited to pediatric patients, is if they have a sodium channel mutation, so this SCN5A that we do see as part of the many things that the sodium channel mutations can do, one of them is Brugada. But I almost always see the heart muscle involvement right out of the, at the same time. So I've not seen kids who come in with a totally normal heart who develop that dysfunction. There's always some subtle clues I find. So I do echoes on my patients who have sodium channel variants, but if they've come in with a normal heart, it's more of a routine monitoring thing. They tend to come in with an abnormal heart right from the beginning. Anyways, that's my experience.
Yeah, nothing to add except I think every patient with genetic channelopathy needs to have at least one echo at some time in their life. And that includes the Brugadas. And then how frequently one does that just depends. I do it very infrequently in the pediatric Brugadas because they almost never show the very uncommon cardiomyopathy. In the adults, every once in a while, and I'm talking less than 5% of the time, the Brugada patient, because of this right ventricle involvement that Shu mentioned, they can get a little bit of right-sided myopathy appearance, almost never a left-sided cardiomyopathy. And so I'll do a scan with an echo, although I'll acknowledge quickly that the echo is not the best imaging modality to study the right pumping chamber anyway. So I think if I were forced to get rid of one test in a Brugada patient, I could comfortably get rid of the echo because they seldom need it. And with that, for me, I'll just say thank you for joining us. I know the SADS team, Alice, Laura, Marcia to you. Great job in putting the day together. All of the speakers from Mario Delmar and Dr. Spears and the others who gave lectures, Shu and your colleague who gave a lecture and stayed to the very end. Thanks to you, Shu. Dr. Tandri, I'm glad you could join us. Good seeing you. So for the families who chose to join us for the annual, thank you. If you did not get a chance to say thank you by hitting that donate now button on that SADS website, www.sads.org, feel free to do that. And we thank you in advance for that. So I'm heading out to the lake, going surfing. See you, everybody.
Enjoy your time. Thank you so much. Enjoy your time. Mike, Shu, and Hari, we really appreciate your volunteering today.
Oh,
Thank
thanks.
you.
Great
Thanks for
information.
having us.
Questions were fantastic. Thank you so much.
Thank
Thank
you. It was
Right.
great. Amazing. And thanks to everyone for sticking with us.
Yes. So on behalf of the SADS Foundation staff and our board, we thank you for attending and hope that you've learned something new. We'll save the questions that were not responded to today to our SADS live program, as Dr. Ackerman was indicating. The next one's July 21st. So for the Q&A there. So I want to thank the SADS team who's worked behind the scenes and planning this conference for you. Anna, Aaron, Jan, Tia, Zach, as well as Genevieve and Alice, who you heard from earlier. So thank you for spending your Saturday with us. We appreciate it. Enjoy your weekend.
Yay.